Good morning. I need to do a ding, ding, ding. Good morning. Welcome to the second day of the SCN2A conference. Thank you. So good to see you all again. The Dad's Night Out was spectacular. The legendary stories they're going to tell of the ping pong played will go on for years. The mothers are going to need to do some serious dancing tonight to make up for that. Now, I'm afraid yesterday we ran over by a single minute. And so as a result, Leah is now here to keep charge of me. I've been warned this might be the last time you see me if I go over again. A couple of announcements before we begin. Then at 9:15, the Super Sibling Project for the Duck Tour is going to meet in the foyer. It's downstairs. That's in 15 minutes, and you'll meet Christina there. It has been made clear to me that I do not count as a super sibling, which I'm a bit sad about, because duck tours sound amazing. For younger super siblings, there will be a meeting the meetup is at 10 o'clock in the foyer, and you'll be meeting Derek. Okay. So now we're going to move on to the beginning of our program, and it is with great pleasure that I introduce Karen, who is the scientific advisor to TASCO for the SCN2A Foundation. Congratulations.
Thank you, Stephan. So I came here because this is my first SCN2A meeting. I came here wanting to meet everyone, but from this perspective, I now realize that I am failing miserably at that goal. And so if you would like to introduce yourselves to me at some point during our breaks, that would be lovely. A picture is worth 1,000 words. And if that's true, then Patricia Weltin's Beyond the Diagnosis collection is worth 1,000 words 1,000,000-fold over. Beyond the Diagnosis's goal is to raise awareness for rare disease by having professional artists paint portraits of children with different rare diseases. Patricia uses these portraits to capture our kids' inner strength, their vulnerabilities, their courage in the face of daunting obstacles, their unspeakable joy, and their amazing beauty. Patty uses these portraits also to challenge those in power, those from the government, from medical institutes, from clinicians and research scientists, to do something to change the world for our kids. Today, Patty is here to unveil the newest and latest addition to her collection. Please welcome my friend and rare mom, Patty Weltin.
I'm already crying. So I thank you guys so much for having me here. I do a lot of events all over the place, but to me, to be with other rare disease families is family. I feel like I'm with family. And I think a lot of parents, despite my kids having a different disease, we're on a very, very similar journey. And the reason, and a lot of people ask me, I'm not a genius. I didn't, I think I'll do this. It was born from frustration. It took 18 years to get my daughter diagnosed correctly. And in the end, I was the one that figured it out. So I was very upset with, I believe that we needed to find a way to engage the medical community. It needed to start with medical students. So somebody came to me and said, hey, I have to paint a portrait for a high school project. Can I paint somebody with a rare disease? And that's when the lights went on. And I said, hey, why don't we do an art exhibit? And never dreaming that we would leave Rhode Island. We started with 17 portraits. We now have over 160 portraits. We have artists from all over the world, as far away as Bali and Thailand. And I think I might have to visit some of these artists as part of my job. But we also have children from all over the world. So I'm really, really excited to be here. The exhibit has, I don't know if any of you guys have followed us, but we have done things that completely were not available to the rare disease community. We were on CBS Sunday morning. You know, the issues that affect all people with rare diseases, you know, not a disease specific, but all rare diseases. We were just in Times Square for the entire month of February on a Jumbotron. Our kids' faces up there every day. They estimated 4.4 million viewers of the exhibit. We're doing museums, we're doing galleries. So we're reaching outside of the rare disease space. And I don't know how you guys feel. I feel like being a rare disease parent, I feel like I'm on an island and it's pretty isolating. And I've been an advocate for 12 years. And even though the island is more crowded, we're still on that island. I want people to know us who would never have otherwise heard or supported rare diseases. And that's what's happening through the goodness and just the heart of the artists that participate and the families. So we're super excited because we got another family, and we'd like to invite the Egan family up and the artist Kimberly Sass to come up, and we got a surprise for everybody. The surprise is that what over here covered. Obviously. Oh, yes. You know what? Let's have Kimberly say a few words because there's going to be too many tears.
Hello, everyone. How are you? So, hi, I'm Kim Sass of Sass Studio. I'm also Harper Egan's aunt. So first I want to say thank you to Behind the Front Diagnosis Collection for choosing SCN2A as a featured rare disease artwork this summer. And for Leah and Sean at SCN2A, Families SCN2A, for referring me as the artist. So I've mainly done advocacy artwork in the sports world with the NHL surrounding gender equity. But this was a welcome change to advocate and raise awareness for my niece and other SCN2A kids. So I'll talk about the painting, even though you guys can't see it yet. So the painting is titled Harper. This painting is a portrait of my niece. I chose to use SCN2A purples, blues, and greens. The pose of Harper is of Harper laying down, smiling among some daisies. Unfortunately, some kids with SCN2A disorders can go long periods of time without a smile. Harper has periods of time when she isn't able to smile, but when she does, she lights up the room and also has the most contagious laugh. She is laying among daisies to represent her joy and cheerfulness she brings to us. We can all take a page out of her book of strength and her ability to smile through this grueling disorder. Harper has the best support system. Her parents, Steph and Sean, both having PhDs, with all of the different meds, as I'm sure you all in this room know, and feeding tube intricacies. They're a great team, and I'm in awe of how they tackle her care with such poise. And of course, her grandparents who are here, some of them, who came to the rescue, always come to the rescue and love Harper. My hope is that this painting being installed and traveling and being exhibited at various places will raise awareness of SCN2A and help us move towards a cure. Drum roll.
Sean, do you want us to help bring the stroller up there? Yeah, closer. It's like a cell phone picture if you don't want. You got it. You're in a 1200.
Great, thank you. So a big round of applause for Kimberly and Patricia. Wonderful, wonderful bit. The other pictures you can see, or some of the other portraits are here. And of course, in the break, do take the time to come and look at them and see the stories associated. We're now moving on to our first session, which is the clinical challenges faced by SCN2A related disorders. Just like yesterday, we're going to start off with that important question: why are we all here? And from this, we're going to hear a family story. And I'd like to invite Amanda and Jim and Harry up to the stage. And a round of applause as they all come.
He gets a little embarrassed when we talk about him, so we're just going to distract him. Okay. So I'm Amanda Van Scoik. This is my husband, Jim, and this is Harry. And we're here today to share his story with you. Thank you. Harry was born on October 27th, 2015. And initially he appeared to be developing normally. But our godson, Matthew, who is 6 months older than Harry, had at the time been recently diagnosed with Phelan-McDermott syndrome. And so we had a heightened awareness in our own life about developmental delays. So when at 9 months old, Harry was not sitting up independently, we pushed for early intervention and he immediately started physical therapy. Generally, Harry excelled through PT. With each session, the therapist helped him with the motor planning steps, and he quickly picked it up. So by 11 months, he was sitting. By 12 months, he was crawling. By 13 months, pulling up and standing. And by 16 months, he was walking.
So at 15 months, he was being reviewed for PT discharge, but we still had some concerns. Harry, he checked a lot of the boxes. He laughed a lot. He appeared very sociable, engaged with us and his sister and our dog. He loved the dog. He could totally identify colors, numbers, but he really had no speech other than a few primitive sounds like e, ga, or ka. We decided to request reevaluations across the board. Instead of being discharged from early intervention, suddenly he was receiving occupational therapy and one-to-one special education services. Shortly after, we started doing, we added speech therapy.
Show me number 2. Where's 2? Good boy. Where's number 8? Good boy. Where's number 5? There it is.
So Harry started having seizures in January 2018 at 2 years and 2 months old. We were in and out of the hospital for that year from January to July. Initially, he presented with tonic-clonic seizures, but as we struggled to find the right medication, he also started presenting with myoclonic tonic seizures, atonic seizures, and atypical absence seizures. After failed success with Keppra, Depakine, and Vimpat, we found seizure control in October of that year with a combination of Onfi and Depakote, both of which he remains on today. But the damage was done. He regressed in a majority of his social skills. He had to be retaught to do things like use a fork and drink with a straw. And during that year, he lost most of the speech sounds that he had. Thankfully, once we found that seizure control, he remains seizure-free for just a few weeks shy of 4 years. He did have a few breakthrough seizures last fall, but after some adjustments to his medication, we are again grateful to be seizure-free for 10 months.
So leading up to Harry's first seizure, and despite the additional services we were starting to see more signs of developmental delay. He was becoming more self-directed in play. His toys often need to be perfectly aligned. He was drawn to and often made repetitive sounds. We received Harry's genetic testing results in April 2018, only a few months shy of his first seizure. In fact, in the 12 months following Harry's first seizures, we received multiple diagnoses, including autism spectrum disorder, apraxia of speech, dyspraxia, developmental delay disorder, and motor planning delays. From then on, we suddenly found ourselves moving from a few early intervention sessions to more specific programs within special schools and constant therapies. We started using an ACD and began prompt speech therapy in 2019.
Do you need something? Help what? Help open? Okay, it's coming. I'll open it for you. Say thank you. Good boy.
Finally, at 3 years and 9 months, his speech started to come.
Chapter 8.
For those of you who were with Harry yesterday, he doesn't stop talking now. So we measure Harry's progress in inches, but over the last few years, he's built those inches into miles. He was toilet trained at 4 years and 9 months, so he still doesn't need a little help with wiping. He learned to ride his tripod scooter at age 6. He started jumping independently at 6 years and 10 months old. At 7.5, he started learning to ski and learned to ride his bike, still with training wheels, but without those foot straps to hold his feet to the pedals. So.
Where you going? What's forward?
And yes, the first time he jumped independently, we were in a bathroom. So I took out my phone and took a video.
Milestones, you can't get around them, right? So not every day, though, is a celebration. Harry has needed orthotics for stability from age 1 to age 7. He's currently not using them, but we're probably on our way back to them. He does struggle with sleep, like many of our kids. And after severe sleep deprivation and multiple sleep studies that he aced, by the way, we use gabapentin to address his overactive limb movements to help him get rest. Us too. He struggles with sensory regulation, and constant sensory seeking impacts his ability to focus and learn. Some days we must have all the lights and music on, all the lights off and the music on. Some days we sit in the dark.
So Harry's the hardest working little boy we know. We use every opportunity we can to focus on his therapy, his education, and integration. He attends our local school year round in a self-contained class, but with the support of a terrific education team. He spent a good portion of his school day this past year learning with his general education peers. Here he is leading independently 23 of his general education buddy peers in his class phonics session. But there's more to Harry's story than just Harry, and we'd be leaving a huge part out of our story if we didn't share with you that Harry's condition also has an impact on our family. Sorry. This is Harry's sister, Morgan. She's 3 years older than Harry, and she witnessed Harry's first seizure at the impressionable age of 5. She has spent every minute of her life being the best big sister to her brother. On the surface, you can see here that she is an amazing teacher and friend to him. She's empathetic, and she's often praised as being the most inclusive and helpful child in her class, acutely aware of others' needs. But what you don't see here is that she struggles with anxiety. She puts immense pressure on herself to not be a burden to others. She struggles with sleep and has some psychosomatic stomach issues as a result of her anxiety. She also panics every time someone in her life needs to see a doctor or, God forbid, be treated at a hospital. So our journey includes not only making sure that Harry has the therapy he needs, but also that Morgan has the therapy she needs, because this is a lifelong journey for all of us.
Right, because this is a lifelong journey for all of us. We acknowledge there will be many difficult moments, and that ours is also an uphill battle. But through that, we can try to fill our moments with the smiles. Harry is just a little boy who loves trains, cars, planes. You can see them all out on our table. Monster trucks and anything that goes. He's actually a roller coaster enthusiast. He calls them the twisties. He's learning to become a Lego master and building his fine motor skills that way. The pool and the beach are his happy place. He loves specifically pop music and he loves to sing. So sing, dance, and find your joy. And we hope this is a little bit more. He's such a ham. Thank you, everyone. Come on.
Thank you so much. I think we can all agree that Harry has got some moves. It's with great pleasure, I'd like to welcome up our next speaker, Anne Berg. Anne Berg's leading the clinical trial readiness study, which is an absolutely critical piece of one day trying to bring some therapies to the clinic. A really, really important part to do. Also, in the last few months, I've discovered Anne has an amazing gift of asking incredibly difficult, but extremely on-point questions. Okay.
Thanks so much. There we go. Well, thank you. And thank you all for being here. It's really a great pleasure to be able to bring you back some data from the SCN2A clinical trials readiness study and update and on some emerging findings with the collaboration with Dr. Al George's lab at Northwestern. There's been a paradigm shift with precision medicine from seizure suppression or symptom suppression to actual disease treatment. And the question is, what is SCN2A related disorder, if not seizures? I think you all know that seizures are an important, but they're not the only, or even sometimes most important part of the disease. And sometimes, for some people, they're not even part of the disease. So what should the targeted outcome be for precision medicine therapy for SCN2A? That's why we've been doing the SCN2A CTRS. And the purpose has been to develop a robust primary SCN2A phenotypes beyond the seizures, identify frequency of neurological and non-neurological morbidities, trial several clinical outcome assessments in people with SCN2A RD with the question of, can we measure better in the face of moderate to profound impairment? Just to make this point, I think several of you know my analogy of if you have a baby mouse and you're watching your baby mouse grow and you want to monitor how it grows, you put him on your bathroom scale and he weighs 0. And a month later, you can see that he's grown, but you put him back on your bathroom scale and he still weighs 0. And that's how so many of the clinical outcome assessments work in children with a disease as severe as SCN2 related disorders. We need the right measures, and that's what we've been trying to do. Fascinating as that is, that's not what I'm going to talk about today, but I just want you to know it is front and center in the work we're doing. We have had the absolute pleasure and fantastic opportunity to partner with Al George's group, and I'm going to be giving you a little bit of a taste of what we're finding, and I think it's really important given all of the discussion that's gone on about variants, their effects, and phenotype. The SCN2A CTRS began a few years ago during the pandemic. I think most of you are familiar with it. How many of you have participated in the study? Yay, thank you all. But overall, across the world, we have 81 families. We've talked about the primary phenotype already in SCN2A-RD, and you've heard about the traditional breakdown of early onset, less than 3-month seizures, later onset, 3 months and older, and then autism or intellectual disability without seizures. We've taken a somewhat more nuanced approach and specifically broken out neonatal onset epilepsy. Neonatal epilepsy has only recently been recognized as its own entity. It used to just be a presumed intrauterine insult and provoke seizures. And the neonatal period is really privileged. It's privileged neurologically, medically, and also for health billing purposes. Beyond that, infancy, the first year of life, 1 month up to the first birthday, is also a critical period for development. It's when the seizure incidence in the population is highest. Infantile spasms, Dravet syndrome, and developmentally in children, it's a bit different. So we broke that out. So our primary phenotype is premised on having epilepsy, neonatal onset, infant onset, and then later onset after the first birthday, and then autism. This is really important. I want to point out that all but one of the children with neonatal onset had their first seizure recognized on either, day 1, 2, or 3. It was boom, right there. The one exception was a baby who was born 6 weeks preterm and had the first seizure at day 19. So just basically had to catch up a little bit before having that seizure. What I'd like to summarize for you today is the medical history. We've talked about seizures and syndromes, so I'm not going to talk about that too much, or if at all, but I'd like to tell you about all the other stuff that's going on in your children and how common it is. In terms of pregnancy, labor, and delivery, 79% of you reported that your children were born at term, 17% preterm. That's a little higher than the general population, and most of that was neonatal onset epilepsy, but it's not a huge signal. It's a little bit. Post-term, not really more than I would expect. 41% reported one or more complications in pregnancy. That's low. I mean, everyone has a complication of some sort or difficulty. But the one thing that stuck out is a fair amount of oligo or polyhydramnios. And this is a little bit more than I might expect in the population, but I don't know what to do with that. 30% had a complication during labor and delivery. Again, not uncommon to have something happen. But what struck me was the 12% failure to progress and the 12% is fetal distress. And I think that's mostly the neonatal onset group. In terms of conditions requiring medical care, including hospitalization in the first month of life, that was 47%. But as you can see, it's mostly in the neonatal onset group. And the most common factors reported were difficulty feeding, jaundice, apnea, and poor responsiveness, largely related to neonatal encephalopathy. In terms of big vital organs, 9% reported any heart condition. What stuck out, though, is that 4 parents wrote in things like irregular rhythm, paroxysmal tachycardia, prolonged QT, and repolarization abnormality due to sodium channel. Those are all pretty unusual. I want to mention it so you're aware of it. In terms of respiratory lung conditions, we did not see a lot of things like asthma, reactive airway disease, but 3 parents reported trachs, and a lot of parents, I don't have the number here, reported things like floppy airways, laryngomalacia, and then also seizure-related breathing disorders or concerns. Dental, dermatology, hearing. Everyone in the population has something going on. There was nothing extraordinary reported here, including early tooth or late tooth eruption. There's not a whole lot going on. So just, probably what you're seeing is fairly typical, although we did not go into great details. There might be something specific to SCN2A, but based on these data, we're not seeing big signals. Where we are seeing big signals are vision. 2/3 indicated a vision problem, including 41% with cortical visual impairment. And I want to point out that this depends on the primary phenotype. The neonatal onset group had about 60% reporting CVI, and this dropped with later age at onset and then lowest in the autism-only group. In addition, though, sometimes in combination with CVI, parents reported trouble judging distance, visual motor impairment, impaired depth perception. Those aren't diagnoses, but they're descriptions of difficulties, which may be related to CVI, or they may be something else entirely. And Becky Homer is here, and she might want to comment on that later. In terms of muscle tone, a lot of abnormalities reported, a lot of spasticity, hypotonia, dystonia. These do not have to be separate in a single child, but what you can notice is that almost everyone has hypotonia. The spasticity and the dystonia are most part prominent in those children, again, with neonatal onset seizures. They're there in the others at very high rates, but really prominent in that very young age group. Orthopedic concerns, a lot of scoliosis, and I think you know that. Now, importantly, scoliosis is not something that shows up immediately. It takes time. And if we look at the child's age at the time the parent filled out the questionnaire, we wouldn't expect any in the babies and toddlers, but we start to see it creep in fairly early in the 2 to 4 year olds, although that child was almost 5. But look in the 10 and older group, 44% reported scoliosis. That's huge. Furthermore, it was particularly predominant in those with neonatal onset epilepsy. And if you put those two factors together, the neonatal onset, who are over 10 years old now, about 60% of them, I think, had scoliosis. So not a lot of numbers there, small numbers, but still something to be to consider. We also saw a lot of parents writing in about hip dysplasia and subluxation. I think that's related to tone. Probably this should go under endocrine, but there's one parent who mentioned osteopenia, and I'm aware anecdotally of 2 other children during the CTRS who have been diagnosed with osteoporosis. In terms of other endocrine issues, 7% of parents reported precocious puberty. This is onset between 5 and 8 in girls and 5 to 9 in boys. This is really rare in the population. That's less than 1 per thousand, maybe about 0.5 per thousand. Of course, it does not show up in the first few years of life, but you can see in the 2 to 4-year-olds and now in the 5 to 9-year-olds, we have 14% reporting that. I don't know why we're seeing less in the 10 and older. It may be that parents didn't think about it or forgot about it. I'm not sure. I don't need to tell you that behavior is a huge issue as well. Altogether, 60% of you responded that your children had been diagnosed with autism or had features of autism. We know that. Dysautonomias, nobody talks about it, but this is the nervous system, and the ANS is impacted when there is a central nervous system problem, or peripheral too. We queried 37 symptoms, and only 14% of parents said their children had none of these symptoms. 86% reported symptoms. The median number of symptoms was 6.5. These are grouped into categories for easier reporting. Median number of categories was 4. And the really, really common ones were things like salivation, swallowing, and aspiration, or chewing rather, temperature dysregulation, peripheral blood flow issues, red skin, blue skin, splotchy skin, a lot of constipation and dysmotility. I bet you're not surprised to hear that. A lot of pain hypersensitivity or insensitivity, and also excess irritability. The other thing I want to point out is the urinary retention. We don't think about that so much, but that can be a really serious problem if it backs up into the kidneys. 11% of you reported your children had autonomic storms. It's not super duper common in your community, but they're terrifying. They're very distressing, and they're not well understood. And then lastly, I wanted to mention sleep disturbances. Your kids don't sleep. Almost 50% of you reported that your kids woke up multiple times per week, 3 or more nights per week. And this wasn't necessarily seizure related. This was without, there's some of it seizure related, but it's even without seizures. And then if we add in those who say their children wake up 1 to 2 times a week, we're at about 2/3, these 3 pie pieces. A few said wakes up now and then, some said never, and a few said I don't monitor, I don't know, and that's fair. So just a quick summary of all of this, and that the things that I think are really common and important for you to keep in mind are that tone, dysautonomia, sleep, vision disturbance, and autism are major features, not, I won't say ubiquitous, but extremely common across children with SCN2A related disorders. Also really important, the scoliosis. Particularly in the neonatal onset group, and particularly in anyone with hypotonia. I think that's where a lot of it's coming from. And then finally, the endocrine issues, heart, lungs, not the most common. They certainly, I don't think they'd be something we'd look at in a trial, and I wouldn't know what the outcomes would be, but just to have on your radar and to let your physicians know to have that on your radar, that these are things that come up in your children. They can be very serious, and you should just be aware of that. Okay, I'm going to stop now and take a complete left or right or turn, I don't know, 180 degrees, because as I mentioned, we have this fantastic opportunity to update you about all of this stuff and how it relates to all the amazing work that you heard about channel function the last few days. Based on some brilliant work that was done by people who are here at this meeting, Roy Ben Shalom, Stephan Sanders, Kenneth Bender, we started understanding the relationship between the gene mutation, that little change in spelling, how it changed the protein, the SCN2A, the NaV1.2 protein, and how that changed the function of the channel. And based on their work, also some work by Marcus Wolf, Begman, and a few others, but those are the 3 studies I've really focused on. We now have an understanding of gain of function mutations leading to benign familial neonatal infantile epilepsy, or to early onset epilepsy with encephalopathy. And remember, early onset in the literature has been defined as under 3 months. We've changed that in our work a little bit. Later onset, loss of function mutations lead to later onset epilepsy over the age of 3 months, or autism spectrum disorder without epilepsy. And then there's a little bit of a story, 1 or 2 patients reported with mixed variants, mixed function variants, and there's an idea that that might be associated with infantile spasms, but the literature there is not terribly robust, I don't think. So we had this fantastic opportunity to partner with Al George and one of his senior scientists, Chris Thompson. In the CTRS and the global survey combined, 69 unique variants were reported. We have some recurrent variants where multiple families had multiple children had exactly the same variant. Chris took those variants and engineered them into hex cells and studied all of them on the Syncropatch 384, fondly known as DUS machine. And Dennis, maybe you can talk to Al about misgendering. A lot of work went into that, a huge amount of work, and I'm not the person to discuss that. You heard Dr. George talk about it a bit the other day, and I would do it a great disservice. I'm just going to tell you the current final characterization of the variants. Chris is still doing a little bit more work on curating data. We don't expect many changes to occur. We have a few that on the Syncropatch, and based on looking at 10 different biophysical measures, a few come out as gain of function. Some come out as mixed function. We have a group in yellow that come out as wild type, no detectable change from wild type. That doesn't mean they're not pathogenic, but in this model, they do not appear to be. And Kevin can tell you a lot about that. We have the moderate loss of function, where there is still a sodium current going through the channel, a severe loss of function, where there's minimal sodium sodium going through the channel, and then truncation. It's gone, complete loss of function, complete loss of protein product. These vary tremendously across our primary phenotype as we've defined it. Very much as you would expect from the earlier work, all of the gain of function are showing up in the neonatal onset, not the early onset. These are the kids with seizures on day 1, 2, or 3. Our mixed function variants are also showing up there. The wild type variants are showing up there, but we also have a couple loss of functions showing up in our neonatal group. As we move to the infant onset, 1 month up to 11, up to the first birthday, we see a lot of mild, moderate loss of function, some of the severe, and I think one child with truncating. We go to the later onset, we have these 2 yahoos out here who just, we don't know what the mixed and wild type, what we have exactly. They showed up here, but we see less mild loss of function and a lot more severe and truncating. And then finally, when we get to the autism only, 1 mild but moderate, and then very severe. And over half of these children had truncating mutations. And I think this is really consistent with what we've seen from the work of others, and it's kind of building on it by pulling out the neonates. I've talked a lot to this group about functional abilities, not in the variants, but in your children. And now I'd like to bring this all together. We've talked about the impairment in gross motor skills, that many children can't walk, they're in a wheelchair, do not have purposeful hand grasp to pick things up, are entirely dependent on a G-tube for nutrition, and are unable to communicate effectively, even with people very close to them, their parents and close caregivers. Based on this, and also a few other things, I began to become aware of the scoliosis and CVI. We've created a very simple non-seizure severity index. And the index is simply a sum of how many of these a child had. So if a child had none of these, the score was 0. If the child had all of these, the score was 6, and then anywhere in between. Okay? That non-seizure severity index tracks really nicely with the primary phenotype. The darker the colors, the more severe, that's how it's done. And you can see that the neonates have the most severe spectrum of presentation. It lightens up a little bit with the infants. It lightens up a lot more with the later onset. And when we get to the ASD, autism or ID only group, that's where we see the least impairment. Now, I do want to point out the children with 0 of those, they're still very impaired. This is not benign neonatal or familial epilepsy. They are still quite impaired, but they have some function. So I've told you Their primary phenotype is strongly correlated with channel function. It's strongly correlated with severity index. And you're probably wondering, well, does channel function drive severity index? Good question. The answer is yes and no. It's a little complicated. We'd sort of expect if that were the case, we'd see a nice continuum of change across the board here with the, again, the severity index being represented by the darkness of the color, but it's not quite that simple. So in an effort to figure this out, we resorted to some exploratory techniques called cluster analysis. And I won't go into what that does, but it basically just tries to group people based on several different factors into the most similar, into similar groups. So we've got 3 factors: primary phenotype, severity index, and gain of function. The question is, how can we group these into groups where the groups are as different as possible and within the groups they're as similar as possible? And the answer is, the first thing you do is you put the neonatal onset into one category over there. They're there. And then we put everyone else over here. Beyond that, within the neonatal onset group, the loss of function children stood out. They had the most severe presentations. Their index was 5 or 6. They either had all five or all 6 of the factors that I mentioned. The other group was all of the gain, mixed, function, and wild type like. Their severity was mild to moderate. There was 1 or 2 in the 6 category, but the median number of severity factors was 2.5, much more moderate as a group. The next group was all of the infant onset. There were 4 from the later onset group, but 3 of them actually had their first seizure right after their first birthday. So, you know, it's a problem with making cut points. I'll have to check their gestational age. These children had the moderate loss of function, and a few had severe loss of function, and their overall severity index was broad, 0 to 5, but like the neonates, the median was 2.5. So it's a mixed group in terms of severity, but trending towards the more moderate side. And then the last group, of course, was all of the autism, almost all of the later onset. This was where we saw the severe loss of function and most of the truncating variants in this group. Their severity index was the lowest, 0 to 3, with a median of 1. And when it was a 1, it was almost always communication. So I think I got it all in pretty much. So just real quickly, thanks for letting me talk fast. A couple take-home points from this last piece. I think we need to be much more specific. Pull out the neonatal onset from the infant, from the older onset. It's really important, developmentally, neurologically, in every possible way. And the realize that those non-seizure phenotypes are much more severe with earlier onset epilepsy, and then least in the ASD group. After 30 years of looking at outcomes in children with epilepsy, this is exactly what I would expect. So it's not a pattern that's really different from any other form of epilepsy that I've looked at. The channel function to phenotype piece, I think we've really getting that locked in. The basics from the literature, from your work, we've got it. The severity of loss of function is strongly correlated with primary phenotype. The non-seizure phenotypes, that's a little bit more complicated, although in general, as I said, the earlier the onset, the more severe. But there is that cluster of neonates with loss of function severity. And we had this fantastic discussion at dinner last night, and we continued it this morning about how do we know what model is really giving us the best understanding of gain versus loss of function? It's a philosophical question that has to become operationalized eventually. Very quickly, and not in enough, I don't have enough time to do this, but this study would never have been possible without all of you, the parents from the family's SCN2A group. Thank you. I was fortunate to have an extraordinary team at Northwestern, the CTRS team, the CWOW team, Chris Thompson and Al George, and none of this would have been possible without the family's SCN2A mutation foundation. Leah, Carla, Jenny, Michelle, and so many others who have come on board for since then. So thank you.
What an amazing presentation. It's just incredible to see that all coming together. Yesterday, Natasha Ludwig gave a talk about what does better look like in SCN2A. It was so good that she's coming back today to talk about cognitive assessment in SCN2A.
It's me again. All right. Hey everyone, so I'm really excited to be here today to talk a little bit about cognitive evaluation and SCN2A related disorders. This is really my wheelhouse. I'm a clinical neuropsychologist. I see a lot of children with SCN2A. So the goal for the first part of my evaluation, I want to talk a lot about kind of the practical pieces of cognitive evaluation. I want to demystify this for you all, to empower you all to be really partners and collaborators within the context of your child's clinical evaluations, okay? You know your children best. Your evaluator may have some skill in neuropsychology or psychology or, speech language evaluation, occupational therapy evaluation, right? But we're all working together to meet the needs of your child. So I hope that this first part is helpful. I have some research findings from the Inchstone project related to cognitive evaluation towards the end. We'll see how much we get through today. I'm going to start my timer, actually, keep myself accountable. She will. All right. All right. Here we go. All right. Just to start off with some vocabulary. Okay. So what's an assessment versus an evaluation? Right? So really, when we talk about assessment or a measure or a test, this is really a tool to gather information in a structured manner about the child or the individual, right? When we think about evaluation, this is really a bigger process. It's the process of gathering all that clinical information. We may use assessments, measures, and tests as part of, the information that we're gathering. And we really take a multi-method, a multi-informant approach. And our goal is to really integrate all this information together to interpret the data within your child's context, right? So I have this nice evaluation flower here that taps into kind of all the different pieces, and there's even more, but this is what fit on this flower. Right, we talk to parents, right? What do you see at home? We do caregiver questionnaires. We may do some assessments and measurements and testing. We also do a lot of informal observation about your child. We take input from the school and their therapists, right? We may ask them to fill out questionnaires too. And then we also look to previous evaluation, and we integrate this all together. And we use this to really make recommendations to inform care, education, kind of living in the community recommendations, right? This also may involve providing some behavioral diagnoses like autism or intellectual disability. So what's the difference between, developmental evaluation, cognitive evaluation, psychological, neuropsychological? What is the difference, right? So they probably have more similarities than differences, okay? It's more about who is conducting the evaluation and how they were trained to interpret and use that information that's gathered and how they're going to apply it to your child. So here's a list of some people who might do different kinds of evaluations. So psychologists, they tend to do more developmental, cognitive, psychological evaluations, and they can make psychological diagnoses. They also have some skill and training and intervention as well, so they can really map on what they're seeing cognitively to recommendations for therapies in school, those sorts of things. A neuropsychologist has similar training, but we also have additional training in how medical conditions impact brain development and then cognitive development, okay? So as a neuropsychologist, I see a lot of children with medical conditions like SCN2, so genetic conditions like SCN2A, kids with epilepsy more broadly, kids with other congenital conditions, kids with brain injuries, those sorts of things. So how does that impact the brain development and then what we're seeing behaviorally or developmentally? And then, of course, school psychologists or educators might do some testing, right? And they want to see what your child's doing so they can really map that on to, their education plans and their therapy plans in school. There's some limitations there. It varies by state and who's doing the evaluation, but they may not be able to make a clinical or medical diagnosis. They can make a educational category diagnosis, which is important for school, but they may be limited in terms of making that clinical diagnosis like intellectual disability or autism or ADHD. Developmental pediatricians sometimes will do assessments as well as occupational therapists and speech language therapists will do some cognitive evaluation. And usually when they do it, it's to really inform and tailor their therapy programming for your child. Okay, If you know me, you know this is my soapbox. Every child can be evaluated. Okay. You may have heard that your child is untestable or child can't be evaluated. It's just simply not true. Any child can see a psychologist or a neuropsychologist, and we can gather information about your child that can be meaningful for their treatment planning. So untestable, when you hear that, I would, this is actually a slide I use with my trainees, right? When I'm teaching them about how to do assessment in individuals who traditionally they may have thought are untestable, right? But the Vineland, that's a parent interview, that can be done on anyone. That's meant from birth to 99 years old, right? So we can get some information from families about adaptive functioning. The Bailey is a direct assessment of cognition. That starts at 2 weeks of age, right? So I use that all the time. I mean, we can gather information. We may not be administering these tests in a standardized way where we can really map that onto the standardization sample and get standardized scores, right? But through kind of what we call testing the limits or trying different modalities to help that child really score and show us what their skills, right? So like, for example, I might do modeling, or I might do hand over hand, or I might do repetition with a child, right? So I'm not supposed to do that per the manual, but that tells me so much qualitative information about how that child learns best. And then I take that information and then translate that into recommendations for their treatment plans through therapies in school. And that is like such a value of an evaluation, right? You also, neuropsychologists, they train us, you're going to use your tests, right? And you're going to use that mainly to come up with recommendations, but that's just simply not true. We are trained to understand brain behavior relationships. Okay. What's going on in the brain and how does that relate to how a child is developing or behaving, right? So we can observe a child and make inferences about that. We can look at how are they communicating just when I'm interacting with them? How do they get what they need? How do they use their hands? How do they play, right? And interact? What engages them most? All this information can be really helpful for treatment planning. And this is a really nice paper. It's written by some of my mentors, Lata Soria and Audrey Thurm, and they did a really nice job because they do these evaluations all the time with individuals with neurogenetic disorders, kids who some might say are untestable, okay? They have written a really nice paper for how to do assessment in these children. I refer to it all the time. And, I would say if someone tells you your child's untestable, give them this paper. They may be a little offended, but you can send them to me, okay? So here you can't read any of this, but this is literally, it breaks down, they've done such a nice job breaking down every kind of domain of function and the methods that you might use to actually gather information that's going to be helpful for your child. So I refer to this all the time with my trainees and myself too. All right, so let's talk about why an evaluation might be helpful for your child, right? So we can obtain behavioral diagnoses like intellectual disability, autism.
Please,
really
there is too much echo.
Main referral question for me, working in an
mute
academic
their
medical
speakers,
center with
please?
kids who may be medically unstable, tracking skills over time, okay? Tracking response to intervention like new medicines. I might do a pre-evaluation before a child starts a medicine and then after they start a medicine. And I speak to their neurologist, hey, are they looking better, or if they have a medical event, let's say they're having increased seizure burden or epileptiform burden on their EEG, like, okay, let's see, how are they looking cognitively now? How are they looking functionally now? Also to determine their weaknesses, of course, for documentation purposes, but their strengths. It's such a unique and amazing opportunity to evaluate a child to really pick up on their strengths so that we can use those to bolster their weaknesses, right? That is so key. Also, determining optimal conditions for skill learning. I talked a little bit about this, how I would test the limits, use different modeling or prompting approaches, document that, right? And then share with school or therapists or who's ever going to work with this child about what works best for them. Okay, then the results can be used to inform medical decision-making, treatment planning, informing supports, interventions. I've talked some about this. Also access to services. Someone mentioned yesterday the long wait list for the waivers. I agree, get on them as early as possible because there's a long wait for those, but diagnoses can kind of help make that a little bit easier to kind of obtain those services when the time comes. All right, so what kinds of questions might you ask your evaluator? I've just thrown up here some examples of things that, I've heard from parents or talked with parents about that I think are really important. So I just kind of wanted to give you a few ideas of things you might ask your evaluator. Okay. So like, what are the diagnoses and how did you generate those? How will those diagnoses be helpful for my child? Do you think scores on the measures are true? They're valid representation of skills or not? And if not, why? What are my child's strengths? Talked about this, super important. How does this compare to my child's previous evaluation, right? Have they progressed? Have they stayed the same? Have they declined? That's important information for you to know. Are results consistent with what is known so far about SCN2A and other aspects of their medical history, right? So SCN2A in itself can have an impact, but what about the other pieces like the impact of the epilepsy or the impact of poor sleep, like Anne talked about, right? So what is the impact of those other medical pieces on my child's functioning? Also, how do these recommendations inform interventions, medical decision-making for my child? Oh my goodness, this is a big one, okay? So lots of times in my practice, I'm gonna give parents a whole laundry list of things that are really important that I think are just really, really things we need to focus on based on my evaluation. But everybody needs to stay sane. Parents need to stay sane. The child needs to remain sane and happy, right? So there's only so much we can do. There's only so much bandwidth we have, right? And so I think that there needs to be time for a child. There's a lot of therapies that are great and all, but there also needs to be time for a child to like be a child, right? That's really important for development too. And so I think, asking your provider, you've given me all these great things, but what are the top 3 things you want me to focus on first? That is something that I really hope that, you feel empowered to ask your provider when they're giving you a laundry list of things. All right. How might these results inform my child reaching their goals? And then how might these results inform a good quality of life for my child? So these are the things that we can speak to as evaluators, and we can work with you on based on the results from our evaluation. Okay. All right, quickly, I'm going to talk a little bit about intellectual developmental disorder or intellectual disability, and then autism spectrum disorder. So these are part of the behavioral presentation in SCN2A, as you know, right? These are behavioral disorders. It means that there's no objective like litmus test, right? Or a blood test for ID or autism, right? This is based on what a clinician observes about the child. And clinicians make diagnostic decisions based on clinical judgment. It's often informed by aspects of the evaluation flower that I talked about earlier. And at present, the cause doesn't really matter when we're making these behavioral diagnoses, okay? So when I'm making a diagnosis of ID, it doesn't matter that they have SCN2A. However, when we think about the recommendations and the care, that's when we consider the etiology and how that intersects with the behavioral diagnoses to really make a top-notch treatment plan. And why do we need these behavioral diagnoses? Well, there's a couple of reasons. So this does give us further specification of the child's needs within the genetic condition. So when we say a child has SCN2A, there is a varying phenotype, as Anne talked about today, right? So having a behavioral diagnosis can be an easy way to communicate to other providers or school team about, kind of what that child might need when they first meet a child. Of course, we want them to get to know them on an individual level and make, really tailored intervention plans. But I think it's nice to just have these labels to kind of quickly communicate to providers. And also, again, I said earlier, I mentioned the waivers, right? We need some documentation of diagnoses at times to obtain services. It's just the way our system of care is. And then from a research perspective, I think that it's important too to have some of these labels to begin to understand the different phenotypes of these rare disorders like SCN2A. Right, quick summary on kind of the diagnostic criteria for intellectual developmental disorder. So it really requires deficits in intellectual functions that's confirmed by a clinical assessment and individualized standardized testing. Okay, so we'll get back to that in a minute. Also deficits in adaptive functioning. So this is like everyday skills. And there needs to be an onset early in the developmental period. These are like the 3 core things that need to happen in order to obtain a diagnosis of intellectual disability. Now, when I mentioned standardized testing, we got some problems there, okay? Which I'll talk about in a minute. And that brings us to our Inchstone project research, okay? But just a little bit more about ID. So you may also see if you have an ID diagnosis, there's some severity specifiers that go with that. So it might be mild, moderate, severe to profound. And those are really just based on adaptive skills or how a child is getting their needs met independently throughout the day. Other ID diagnoses you might see. So one of them is called intellectual disability unspecified. So this is for children over the age of 5 who, we're just really not quite sure how severe their intellectual disability is quite yet. And there could be a number of reasons for that. One of the reasons that comes up a lot for SCN2A for me when I evaluate these kids is the CBI component. I'm not quite sure how much that's impacting their performance and also whether they're adequately supported at this point in time. A lot of our standardized measures can't really accommodate for that, and we try our best during our assessments. But that might be a reason why I would say, I'm pretty confident this is intellectual disability, but I don't want to label the specifier quite yet. Let's let that child have a little more time and get some more accommodation and support for their vision or whatever other aspect is giving me pause about severity. And then global developmental delay is another one you might see. Okay. And that's really reserved for kids under age 5 who have impairments in at least 2 different domains like communication, motor skills, for example, social engagement. So that's the way that we kind of capture that when kids are really young. Development can change over time. So that's why we have that sort of as a placeholder there. Not every child who has GDD goes on to develop ID. A lot of them do. Okay, back to those measurement problems. We have so many, there's more than 99. Sorry, Jay-Z. So this is a schematic that I developed to kind of articulate this, right? So for children who have moderate to profound impairment, there's a lot of barriers to assessment using our standardized developmental tools. So for example, kids who are nonverbal or who have significant communication impairments, kids with motor limitations, kids who have behavioral dysregulation. We can't really accommodate for those things if we're going to administer these tests in a standardized way. As I mentioned earlier, to be honest, I don't do a lot of standardized assessment. I test limits a lot in the context of my evaluations. But when we're thinking about doing things in a standard way, which is important for research, and it is important, we need to get there. We need to be able to have tools that are standardized but are flexible at the same time. Okay. We need tools that capture variability in skills for those who are more in the severe to profound range of impairment so that we can track development over time, right? If they're getting 0 points and then I see them next time they got 0 points, but their parents telling me they've gotten better, like the tool isn't helpful at all, right? I incorporate the parent feedback into my evaluation, right? That's super important, but we're talking about measurement problems here, right? So that's an issue. And also, if you're not getting many points, we can't, well, I kind of talked about this, you're not going to see meaningful change over time. So we need good measures to inform individual patient care, to document natural history of rare disorders that we don't know a lot about, and then also for clinical trial readiness, so our clinical outcome assessments. All right, this is a beautiful, it's a little fuzzy, but it's beautiful, this graph that Berg developed. So this articulates one of our problems we have with our standardized assessments, which is, I'm just checking my time. Okay. Which is essentially, this is on the x-axis here on the bottom, you'll see this is development over time. So 1 year, 2 year, 3 years, 4 years of age of a child. The yellow line is actually their raw scores on an assessment. So the skills that they're developing over time. This child's clearly developing skills, right? We would all agree. But that blue line is really the score you need to get the lowest possible standardized score. So let's say it's the Vineland, the lowest possible score is a standard score of 20. Okay. So over time, that child's score is always going to be a 20, right? But that child, so it looks like that child didn't make any progress, right? But that child made progress. We can all agree with that. So, we need to look at other ways to capture that progress. Maybe looking at the raw scores is the way to go. There's some psychometric problems with that, but I think that we really need to focus on that and think through how to solve those problems. Dr. Berg did a really nice paper looking at some of these challenges, specifically in SCN2A, and definitely highlighted these kind of floor effects and the issues with these standardized scores. Last summer at this conference, we collected some data through the Inchstone project. I mentioned a little bit about this yesterday. We looked at 10 kids with pathogenic variants in SCN2A, and we administered the Bailey which is a direct observation, kind of a play-based assessment of cognition. And then we did the DP4, which is a parent-reported questionnaire of cognition. And you can see here that a really high percentage of these kids were performing at the floor when we're considering standard scores. Okay, so this illustrates our problem. But when we look at raw scores, we have some nice variability there. On some measures, it's still, not a lot of variability. There's not a lot of raw score points. So there's still some issues, but it's better than, getting the lowest possible score, which is totally unhelpful. So clinically, just so you know, I know we're talking about research now, but clinically, I use these raw scores a lot when I'm looking at child's progress over time. Okay, so I think I'm out of time, but want to make just one more point. Well, I kind of made that point already, so we're going to skip that one. So this, I just want to say one more thing about the Inchstone project. So we are really working to develop better measures, developmental for cognition, development, functional outcomes that are really meaningful to families. We need tools that can measure the Inchstones, right? So these kids, some may make milestones, some may not make milestones. So we need to be able to have tools that measure those Inchstones to inform patient care and also research. I want to just highlight one quick thing because I think this is really cool. CVI is a big issue in this population, as Anne mentioned. And so one of my fellows, Phoebe Albert, is working with me and some other neuropsychologists at my center, as well as with Becky Homer, who's a teacher for the visually impaired with expertise in CVI, to think about ways that we can accommodate CVI when we're giving the Bailey scales of infant and toddler development. So we're working together, and Dr. Albert, my fellow, is writing up a paper now on her findings. This was a poster from the American Academy of Clinical Neuropsychology, but the goal of this paper is to guide clinicians on how to accommodate a child in a way that we can still use the standardized scores, accommodate their vision needs, specifically their CVI needs. So we're really excited about this. We're so lucky to work with Becky Homer. So I'm just like pumped about this. And I'm going to skip that. Again, just a plug for the Inchstone Caregiver Survey. Please participate if you want to be a part of kind of this effort to make better measures for our severe to profoundly affected kids. So thank you so much.
So welcome our last speaker up here. I remind you, in front of you, there are cards on your tables and pens, and please do write your questions there. At the end of this talk, we'll start collecting those and bring the questions up here. I'd like to welcome Maireade McSweeney up to the stage to talk about the gut-brain relationships. Thank you very much.
All right. Hi, everybody. I hope you're having a good morning. It wouldn't be a talk for our GI group if people didn't have some sort of food in front of them. So that's great. I want to thank the SCN2A Foundation for letting me come talk today, as well as Dr. Olson. We share a lot of patients. So today, what I hope to do is review some of the SCN2A gastrointestinal related symptoms that I found when I was trying to do a literature review and preparing for this talk, and just review with you a little bit an assessment of what we do in clinic, because I am a clinical gastroenterologist, when we're assessing a patient with neurologic disability and how we go through assessing their oral feeding, their nutritional status, review some of the factors that go into enteral tube decision-making, touch upon reflux, of which I'm sure many of you have seen in your children, and of course, constipation, and then hopefully show you the benefit of having a multidisciplinary approach to your children. So you already heard from Dr. Berg and many of her colleagues a little bit about all the various spectrum of SCN2A variants. But as you know, they can vary in severity and the type of symptoms. And again, there can be a subset with a symptom onset in infancy. And when you initially look what's published right now, they just talk a lot about associative gastrointestinal disturbance. But as many of you know, gastrointestinal and nutritional difficulties are frequently reported in patients with neurologic disability. So again, I thought it would be helpful to review our approach that we use in our clinic for patients presenting with neurologic disability. So gastrointestinal functions such as feeding, nutritional status, upper intestinal motility, and lower intestinal motility, or when they go wrong, the dysphagia, the malnutrition, the reflux, and the constipation are all tied into an infant and child's brain and neurologic development, their overall tone, whether they have hypertonia or hypotonia, or a combination of the both, what their posture is like, their ambulatory status, their seizure profile, and what sort of central nervous system medications that they may be on. And it's known that there's a strong bidirectional communication between the central nervous system and the enteric nervous system under what we call the gut-brain axis. That's why many of my colleagues call the GI tract the second brain. And in fact, neural communication has integrative roles in gut function, and this central regulation plays an integral role in the physiology of the GI tract. And to be honest, we're just beginning to understand the various hormonal, immune, and neural pathways that are involved in the GI tract and brain. And many of my colleagues actually are studying the gut microbiome, for example, and how that impacts patients' neurologic disability, autism, and in the adult world, even things like Alzheimer's. But knowing that there's all this communication, let's review some of the considerations. So whether the first thing is oral feeding milestones, right? Whether it's learning to nipple feed as an infant, take dissolvables, potentially as a 10-month-old, drink from a cup, or your 3-year-old telling you what pizza they want for lunch. There's many different feeding milestones that have to take place in those first 3 years of life. And sometimes when there's neurologic disability, there can be delayed or difficulties in achieving these milestones. And it was interesting to hear what Dr. Berg said today, because there's a very old study actually of parents of 48 preschool children that had cerebral palsy, and almost half of the parents noted that their child's inability to feed was the first indication of a neurologic issue. And in addition, I will say that speech delays also often tie into feeding delays in infants. In addition, the advancement of oral feeding skills are tied closely to a patient's neurologic development and comorbidities. So if a patient was born premature, that's also going to affect the timing of them developing those milestones. If there's presence of any other anatomic abnormalities, you heard about some of that laryngomalacia, or presence of a cleft palate, for example, or a laryngocleft, that also is going to affect their ability to advance on their oral feedings. For patients with autism spectrum disorder, it is very common to have feeding difficulties. It's very heterogeneous in nature. In the literature, they report about 62%, but anywhere from 30 to 84% of children with autism have feeding difficulties. And these can vary from oral motor delays to food selectivity or sensitivities to various textures, tastes, smells. They can also have a diagnosis of restricted eating or avoidant restrictive food intake disorder, or ARFID, mealtime related behavioral difficulties. And of course, this all ties into then caregiver feeding stress. And when we think about the actual swallow function, which is the oral phase, which requires that lip closure, the chewing effectively, that then you have to move the food bolus to the back of the mouth, which is the pharyngeal phase. You have to lower the palate and then get it into the third phase of the swallow, which is the esophageal phase. This is why we really think it's very important for all children with neurologic disability to have a clinical feeding assessment by a trained therapist. In addition, our team encourages to obtain a video fluoroscopic swallow study to understand all of this oropharyngeal coordination and potentially a child's risk of aspiration, because it may change the method of thickening or pacing of how you're going to feed that child. One of my colleagues in my center actually did this pretty cool study from a couple of years ago that looked at almost, I think it was 450 children under the age of 2 that had swallow studies at Boston Children's, of which almost a third had a neurologic comorbidity. And you can see that the varying types of symptoms of whether a child aspirated or didn't aspirate was very variable. So there was the classic, you think about choking, reflux, coughing, noisy breathing. But one of the messages for you is that actually just the symptom of parents saying they had reflux also was there and may mimic symptoms of aspiration, especially in kids under the age of 2. And one other point just to remember is that kids under the age of 1 may actually have no symptoms at all and be found to have aspiration on their modified barium swallow. This was also brought up earlier too in Dr. Berg's talking about the phenotypes was oral secretions. Those are heavily tied into a child's dysphagia because they often can have decreased salivary control. That's due to lower muscle tone or sensation that leads to decreased airway protection. Sometimes they'll actually have decreased swallowing frequency or medications that can affect their having higher amounts of saliva. Drooling, technically in the literature, if you ask your otolaryngology colleagues, are considered abnormal after 4 years of age. So this can be drooling out of the front of the mouth, or it can be sometimes some of that gurgling that you hear in clinic, or at home, which is that pooling around infants' larynx that then can potentially increase their risk of aspiration. Treatments can include a variety of medications, such as anticholinergics, oral sensory motor interventions, potentially surgical interventions. And these all, again, want to do very closely with guidance by your local OTs, SLPs, otolaryngologists, and pulmonologists. So again, oral feeding, you really want regular monitoring of oral function because it's a dynamic process that may change over time. We heard that in Harry's story that, even after having the seizures, he had to kind of learn how to feed again. So again, it could be a moving target that you want to work with your team. Also, of course, if there's ever any severe illness, last year was an awful RSV flu season, that can also really sometimes change the safety of whether a child can feed effectively and safely orally. We always in our clinic try to promote oral feeding if it's nutritionally sufficient, safe, stress feed, and feeding times are not prolonged. But again, you just also have to be mindful of that oral secretion management. So moving on to how we think about infant or child's nutritional status, we do monitor what we call anthropometrics, right? That's the looking at the length, the height, the weight of the infant and child. But of course, this is often sometimes complex in patients with joint contractures, spasticity, scoliosis. So in general, the trends of your infant and children are very useful to us. We always say to consult with a pediatric dietitian because they also can help if they're having trouble getting some of these measurements to use alternative measures for linear height, such as knee height or tibial length, or skin fold thickness can give them an estimate of a child's body fat. We also recommend in all kids with neurologic disability getting a general annual assessment of micronutrients. And whether it's oral feeding or through an enteral feeding tube, enteral nutrition really is critical to an infant and child's cognitive and neurologic development. It also helps in development of intestinal mucosa, the gut immune system, giving them a diverse flora, and overall helping with their gut motility. So one of the questions that often comes up is, well, when do you consider initiation of enteral tube feedings? In general, we say, if there is need for assistance with medication administration, because sometimes some patients can be on many anti-epileptics, which just get difficult for them to take by mouth, or if they have an inability to safely eat or meet their calorie or fluid needs by mouth, or inadequate weight gain and growth. And our European Pediatric GI Society also came together a few years ago with some guidelines for the nutritional assessment of patients with neurologic disability, and they came up with these red flags that you want to look at physical signs of undernutrition, such as if there's any presence of any sacral decubitus skin problems, or if there's poor peripheral circulation, if a weight for age Z-score is under the -2 range, a tricep skin fold thickness is less than the 10th percentile, or a mid-upper arm fat or muscle area is less than the 10th percentile, or faltering weight and or decreased weight gain velocity. I will say in clinic, practically, the one that we use the most is probably that last one listed on that page. There are many options for enteral tube feeding. There are nasogastric tubes. There are ones that go through the nose. There are nasojejunostomy tubes. There's gastrostomy tubes. There's gastrojejunostomy tubes. And there's even something called a primary jejunostomy tubes that we do in certain cases, but not that commonly. And when you require enteral feeding, we usually start with nasogastric or nasojejunostomy tubes first, because they help us understand a patient's general feeding tolerance. It helps us optimize nutrition prior to G-tube placement if they are malnourished. And it allows sometimes, if it's been a temporary virus or illness, that you can then transition back actually to full oral feeding. If you need more prolonged enteral feeding assistance, of course, a gastrostomy tube or a gastrojejunostomy tube, if there's gastric feeding intolerance, can be present. And this is just one of my patients over here on the right. He doesn't have SCN2A, but he has another chromosomal abnormality. And it's just a reminder that G-tubes, that like you've heard earlier this morning, it's not all or nothing. We still sometimes have many patients that do a combination of feeding what they can by mouth, but if they get tired, or if it's just not a good feeding day, that they can do the rest through the gastrostomy tube. And I always use this in some of the slides, in some of the talks that I give, because it's actually a really nice summary that actually was a systemic review of 11 qualitative studies assessing parents' decision-making around G-tube in patients with neurologic disability. And they came up in 3 main concept areas that impacted families' decision around the G-tube that I think we as clinicians probably need to consider when having these conversations. Oops. I was thinking there was a pointer, but there's not. The first one on the left is just knowing where your family is coming from with their cultures, their understanding of what their child's prognosis, diagnosis is, and how they feel about potentially undergoing a G-tube, their values of what they think in enjoyment of feeding, how they feel about if they will have loss of some of that oral feeding skills if you place the G-tube, and then what information practically they're getting about the process of placing the G-tube itself. And I think if we can probably tackle these 3 domains in a more effective manner and actively engage all of you, I think it makes for a better conversation when the time comes about thinking about G-tube placement. And ultimately, it is for sure just a continual balance. We are trying as gastroenterologists to promote adequate weight gain and growth, and also promote safe oromotor feeding skills and general development while minimizing the caregiver stress and all the points that are going on in the family unit. So moving on to gastroesophageal reflux disease, it is also very common in kids with neurologic disability. If you look in the literature, they say that abnormal EEGs in earlier onset of neurologic disability have been associated in patients to have a higher reflux burden. Interestingly, we think of reflux as both acid and non-acid reflux, and higher non-acid reflux burden has also been found in patients with neurologic disability. Interestingly, for us to keep in mind as gastroenterologists is that this is especially sometimes common if their patients are also found to have significantly delayed gastric emptying. I think because then the meals are just sitting in the stomach and they have more likely to have that non-acid reflux after a meal. Other gastroesophageal reflux considerations include impaired esophageal motility, which can happen in patients with neurologic disability. They can have decreased esophageal clearance, which can then also in turn worsen their reflux symptoms. And then there can be a variety of factors that can worsen a child's reflux. If they're in a prolonged supine, that means lying flat state. If they have scoliosis, which we've heard a lot about this morning. If there's any increase in intra-abdominal pressure, which sometimes can happen with seizures, if there's a lot of coughing, if there's symptoms of an upper airway obstruction and various medications, or if there's an anatomic abnormality such as a hiatal hernia, those can also worsen an infant or child's reflux. And then we have to keep in mind what we call GERD masqueraders. Those are things that seem like reflux, but they're actually not. We already talked about one of them, the aspiration, especially in kids under the age of 2. There is also a phenomenon called rumination syndrome, which is repeated regurgitation and rechewing of stomach contents that regurgitate after a meal. And then milk protein allergy also can mimic reflux in infants under the age of a year. Blenderized tube feedings is a common way now that we use in our enterally tube dependent kids to help with reflux. It allows for commercially available or homemade real tube blends through a G tube or gastrojejunostomy tube. One of my colleagues published a paper on how it improved gastric symptoms of nausea, vomiting, reflux, and constipation. There's also some data coming out there now about blenderized tube feeds promoting family engagement, improving their quality of life and inclusion in the family. But I will stress, and can't stress this enough, that it has to be done with close dietitian oversight, because sometimes also patients with neurologic impairment may actually need higher calorie needs on a blenderized tube feed, and we got to make sure that we're getting their macronutrients, their proteins, carbs, and fat, as well as micronutrients. All your B vitamins, zinc, selenium, you name it, are being met by the diet. But I'm a big fan. Fundoplication is sometimes you may sometimes hear about. Certain centers may perform a fundoplication at the time of a G tube. It's where they wrap the lower esophagus, the stomach around the lower esophageal sphincter to prevent any intractable or gastroesophageal reflux. The biggest thing to keep in mind is that there can be a lot of post-procedural complications. If you can think about it, you now have an obstruction in your lower esophagus. So that's sometimes if you do have esophageal dysmotility or you have oropharyngeal dysphagia, that can lead to worsening dysphagia, gagging, retching, gas bloat, aspiration risk if there is esophageal stasis. And then, of course, sometimes the wrap itself can become slipped and unwrapped, and you need a repeat surgical procedure. This should really only be performed after careful gastrointestinal assessment and consultation with a surgeon. For reflux treatments, we often think of thickening of oral or gastric feeds, like we talked about with blend feedings. Antacids, 100%. If there is acid reflux or any signs of esophagitis, if there's been an endoscopy, prokinetic agents can be helpful if there's delayed esophageal or gastric emptying. And you want to just, again, like we talked about, try to limit some of those other controllable reflux triggers, ensuring all your patients have a stable airway clearance regimen, good secretion management. And I also do promote a good feeding and sleep schedule. Your GI tract does like time off feeds. So it's nice to have that time of what we call the fasting state and give it a break. And of course, fundoplication is an option if there's severe reflux and life-threatening illness. Just one quick slide. This could probably be a talk in itself on a ketogenic diet. I don't consider myself an expert, but I see a lot of kids with the neuro team that is on ketogenic diets. This is a strict diet, high in fat and low in carbohydrate to reduce seizure frequency. It's a spectrum of diets, and I think it depends on your oromotor abilities of what you can do. It can be anywhere from a modified Atkins diet to a low glycemic diet, and varying the classic ones that we think of, the 2-to-1, the 4-to-1 ketogenic diet ratios. One thing that we always keep in mind as gastroenterologists is that 30 to 50% of patients may have side effects from the diet. So this can include vomiting, diarrhea, abdominal pain, constipation, lethargy, and I know they're always tracking the lipid levels to make sure those are staying stable. Hopefully your team can treat this with dietary adjustments, medication, and other interventions, especially if the diet is going well for the seizure control. I only have one slide on constipation, but I'm sure because I am more of an aerodigestive person, but this is often a conversation in my clinics. Constipation is very common in patients with neurologic disability. We diagnose it by stooling history, dietary assessment, abdominal, and of course, we always like to look at the perineal exam just to make sure that there's no spinal abnormalities that you can see around the anus. We assess patients' tone, mobility. That's very helpful to know. Are they getting on the toilet? Are they not? Are they getting in a stander? Are they not? Because all those things can also help with their defecation. Disimpaction is definitely available if there's a concern for rectal fecal impaction. That can be either enema therapy or higher dose osmotic laxative therapy. And then, of course, initially for constipation, we do standard initial treatments with osmotic therapies or stimulant therapy. Some patients that are very hypotonic may need rectal stimulation with suppositories to help them to go. And there is a whole new world of secretagogues out there for some of the older children that have really changed some of our management of constipation as second line agents. And of course, another reason we love blenderized diets is that they can helpful for boosting fiber intake, especially for patients that may not be getting a lot orally in their diet. This is just a plug again, as I wrap up for a multidisciplinary team approach. You really want to work with your neurology team to understand what they think about their function and the ability and how that's impacting the GI tract. Of course, there's us, the gastroenterology team, the speech language pathology team. I love them so much, along with our dietitians. We sometimes partner with a complex care pediatrician who sees a lot of our patients that have multiple specialists involved, because I do know that can be overwhelming. We also work closely with our ears, nose, throat, and pulmonary colleagues, and of course, your primary pediatricians. And this is just a slide. It's a paper that we actually have in progress that we were looking at care integration of our experience of patients coming to our aerodigestive center. That means families' experience with care integration across the whole care spectrum, from the clinic, hospital, to the community services. And the dark gray is patients who are in our program, and the light gray are those who are just new to our program. And they break care integration to how families felt with access to care, provider communication, care goal creation, family impact, and team functioning. And it was actually because we spend a lot of time working as a team, it was nice to see that people thought their experience with care integration was higher after being seen in our aerodigestive center. I don't have to tell all of you, but connecting with community and hospital services is very important, especially from the early age. I promote it as soon as you can get into EI, please do. And we love to partner with them. And that's it. Thank you.
I think you feel comfortable. Could I invite Anne and Natasha up to the stage for our panels? Remember, again, the questions are in front of you. And as they come up and the questions come up, I get the chance to ask my first question. There we go. Fantastic. Thank you.
Oh, thank you.
Oh, wow. Good. So, we're just going to start off with a question. What do you think are the likely primary endpoints for clinical trials? Natasha, do you want to start?
Right. Well, I think it should be whatever is meaningful to families, right? And so I think that's something that we need to continue to explore. Gosh, I feel like I'm promoting the Inchstone project a lot, but we are doing some work collecting data about what is meaningful to families. And that's really the first step when we think about clinical outcome assessment development for clinical trial readiness. If you look at the FDA guidances, they say the first step is thinking about what is important to patients and families. And so we need to do that kind of qualitative work. And so that's really the goal of our caregiver survey. We're trying to start there. We've also started to do some, see how our measures work in this population to learn about, which tools may give us the best endpoints. But we really need to back that up with what the families see as important for their child's quality of life and for their family functioning all around. So, well, I'm biased, and I think that development is important. It does seem to be rising as a very important domain or concept of interest to families. So things like communication, both expressive and receptive, as well as gross motor skills. GI actually has come up to also be really important. So I think that that these are going to be important endpoints for us to continue to explore and validate. So anybody else want to say anything about that?
Yeah, I think from, yeah, it's okay. From the CTRS and from some of the qualitative work we did last year at the Columbus meeting, communication is really rising to the top. And what's really important though, is that even though we have some communication levels that extend down, okay, we're not bottoming out with them in the SCN2A community. We don't have great granularity down there. Natasha's actually been working on some measures that get at sort of pre-communications. Are children even aware? Are they able to respond to stimuli in a way that would be the basis for communication? So, and just from discussing things with you, I think all of you, I think communication is the foundation for us being human. We need to know, we need to be able to understand children's needs. They need to understand us. And it's a real big start, big piece. I think the sleep also, and again, that's not all seizure related, but it's a huge issue for so many. And that's just parent report of children waking up. We don't know about the rest of disordered sleep. And that has a huge impact on cognition and behavior. So that's another piece that I'm kind of curious about for this group. Also, just to plug the InStone project, we are in the CTRS, we did not do an explicit request for what is your greatest, your biggest priority. The InStone study is, what is your biggest priority? What do you want to see fixed? If you could fix one thing today, what would it be? And those kinds of data, if we can get enough input from your community, you can have those data back and use them to advocate for your community. So please consider doing that.
We have some GI questions. So firstly, are there any risks of long-term use of antacid medications?
Short answer is yes. We used to give them out like water, I would say, when I was first a resident fellow back in the 2000s. So general risk to be mindful, especially in kids that if they have any weight-bearing issues, is it can affect their bones. Your GI tract has acid as a first line of defense against various viruses and other pathogens. And so if you need it, you need it. If there's esophagitis, if there's acid reflux, you definitely can stay in it. We try to use the lowest dose possible. And especially in kids under 5, try to use, if needed, a little bit more of the histamine blockers rather than the proton pump inhibitors that tend to have more side effects.
Thank you. Is it common for reflex or constipation medications to stop working after a while? And when should families consider changing the medication?
Good question. I think it can be a moving target. I think it depends on, again, some of the diet, mobility, other meds. Anti-epileptics are very commonly have a side effect of constipation as well. So that's something to talk about with your neurology team. And so they technically should be continuing. I just wonder sometimes if there's other things that are changing in a child's body and things that may be affecting their response to the medications that may have been on for some time.
The question about a teen problems with constipation and reflux getting worse. They've been having difficulty maintaining hydration and become dependent on suppositories and enemas. Is that a problem long term?
I know, I feel like it depends. I would say you would maybe want to talk to your GI team about what's happening, because again, fiber and fluid also can affect the constipation. It's a very, well-defined circuit. I would say that some patients with severe hypotonia and other needs may need more rectal therapies, but I know also for kids with autism, things like that, that is just off the table. You just cannot, it is very difficult and it's just too traumatic to be done. So there, again, as you get older, there are these more secretagogues, second line therapies that can be used for constipation. So it'd be good to circle back with your primary GI team if it's still remaining a problem or if there needs to be further motility testing.
Fantastic. We have 2 questions about the microbiome. The first is, do we know if there's an altered microbiome in SCN2A related disorders, and if it differs from the autism microbiome? And then secondly, is there any work on microbiome balancing methods like fecal transfer as therapy?
Oh, that's a good question. I am not, we are a division of 60 or 70, so I'm not a microbiome expert, but I would say people are looking at this. But circling back to that, one of my colleagues did a nice study looking at proton pump inhibitors. Actually, that was the initial question a few times ago, and their impact on the microbiome and how that is changing patients' flora. I would say there probably is a large group looking at it with autism spectrum. I do not know, it is not an indication that I'm aware of for fecal transplant yet. I know chronic C. diff, and they're even looking at it in inflammatory bowel disease for fecal transplant, but definitely feel free to talk to me offline and I can ask someone else who may know that.
I would add thank you. From the autism literature, it's very clear that the microbiome changes because of autism, not the other way around. And so a lot of it's the restricted diet leads to an altered microbiome. So now whether that means that actually working hard on diet and making a rounded nutrition is the answer rather than fecal transfer hasn't been shown yet. But that causality link, I think, has become quite clear. We're going to flip to sleep. Are there any cases where there's excessive sleepiness and an inability to stay awake?
That's a great question. I will have to go back and check that. But I rather suspect that there are children who don't sleep well at night who then are not awake during the day. Yeah.
Are there any abdominal epilepsy or seizures, and are these common in SCN2A kids?
I don't know.
Yeah. And it's a slightly controversial stalk of a seizure outside of the cortex, which is an interesting, there's a bigger picture also for dysautonomia, but the idea that the nervous system could have something like a seizure outside of the cortex makes some sense, but it's a controversial question.
I would pretend to know.
Yeah, I mean, there is a whole functional disorder of cyclic vomiting, abdominal migraines. I think that can probably happen I think it can happen in any patient. So again, it's just kind of making sure other things, it is kind of a little bit of it's a clinical diagnosis like irritable bowel syndrome, and you just want to make sure other things have been checked off, that it's not contributing to those symptoms, but it could probably happen. Yeah.
Great. Two questions about gut sensitivity. So firstly, can the gut sensitivity associated with SCN2A related disorders make these children more susceptible to viruses and stomach bugs?
I don't know. I don't know the answer to that. Yeah.
It's a good question.
That's a good question.
And then similarly, can gut sensitivity on the microbiome affect the efficacy of anti-seizure medications over time?
I don't know. I don't know. Heather, do you have any thought on that? I'm not.
I mean, really good question. Yeah. Yeah. So some of these will inspire us to future work here. Next, the composite severity score. What would that need to be ready for use as an endpoint in a clinical trial? And is that the direction you're heading? This is I think the loss of function severity, a composite
score, or just
the non-seizure.
Exactly.
Oh, that's really not a trial outcome. That was just a way to get an idea of the severity of the overall non-seizure presentations. The more things you had, I would never use that as a trial outcome. Because you're not going to change the bar very quickly on in a wheelchair versus not in the course of a trial, or using hand versus not. That's just not going to be a very helpful. And you're not going to change scoliosis or not except through surgery, right? So it was not intended that way. It was really for phenotyping.
Thank you. Yeah. Some questions about the keto diet. Been told that the keto diet is not a lifelong treatment. What should you do if it's working, but it's not a long-term treatment option?
but it's not a long-term treatment.
Yeah, well, let's start
watched
there.
you, but I'm like,
Can
I
you
don't
be
know
on the
what else to
keto diet
do.
lifelong?
I don't know, it's in waste.
Heather, do you want to answer that?
I had a good chuckle. We had waste soup.
I'm guessing that there were like plates and stuff dumped too.
Probably.
So my guess is that there was some bleach, and then people came down that actually had
Liquid in them.
stuff themselves. Yeah, like
That's not.
I don't dump bleach in, you know.
No, I'm aware.
So what's the longest you've been aware of someone sticking on the keto diet?
It's a waste container. It's fine.
Are the people
I needed
managing
that chuckle.
years?
My cells are thoroughly
Yeah.
dead.
For sure. For sure.
So
5 to
I
10
have the
years.
plate still. I'll probably have Denise.
And
just
can someone come
reconfirm
off the
before
keto
I
diet
throw
and
the
go
plate
back
away that
onto
they
it?
are, in fact, dead.
Yeah. Was it a yes? Is the nice simple? We like answers like that. Good simple ones.
The stuff is set up for CGM tomorrow, and I'm going to try to make this my last
Anne,
CGM.
can your
so
slides be
it's
available? Your data shared?
Uh,
That wasn't from me.
They're not my data. They belong to
Jeez.
SCN2A families. So yes, and the slides are available.
We had a whole conversation yesterday about my GFP experiment because like
Yeah.
it worked, but like it didn't work. But like also,
But
I'm
they-
happy where it is. because
Fantastic.
it's the first time
Contact
we tried
Leah
it,
for a data transfer
and,
agreement.
like, I think I have a
Fantastic.
good
There we go.
plan.
And then, and again, if
No, it
individuals have
doesn't.
the same variant, how similar were the non-seizure phenotypes?
Yeah.
Oh,
Like-
that's a great question. They, in terms of just counting up those 6 items, they
Science,
were
calm
pretty
the
similar.
stress.
There might have been
And
different
listening to the
by a
SCN2A
point or two, but there,
conference, and they're
it's
having some
a
pretty cool
small number
conversations.
of children. So I've got
Um,
2 children with
right
one
now
variant,
for-
4 children with this variant, and there's a little bit of variation, but they're very similar. And their seizure phenotypes, the primary phenotype was, I think, right on. Except, there might have been one who was neonatal and one infant and one later onset, but for the most part, they were right on.
Wonderful. I have finished our questions. So that brings us on to a 20-minute break. We'll be back here in 20 minutes. And I think that is all the answers I have. Please end by thanking this spectacular panel and these wonderful talks.
Do you remember Stephanie Bayless? Yeah, Michigan, ASXL edition. Yeah. Our foundation is yeah, so I was right now the talks are happening on basic science, tomorrow information. Yeah, Next year, there's an executive director. She's brought her back. She's not related to her background. I'm gonna email you. I told her because together a list of just all the people who might may be interested in SSL, like things that we mentioned connect with you. So Amanda put this in this morning. And I was like, wait a minute, I know that, yeah. And so I emailed her, I was like, I didn't know if you were going to that. I didn't know if you connected. And she's like, no, but if you see it, tell me. Yeah, let me send you the agenda where it is and everything like that, please. Yeah, awesome. Yay! And also, so, oh my gosh. She's who I want to pick up her and Amber. Those pictures, like, later. Awesome. No. I don't know. I might have it. I have to do some time. Yeah. I'll email it to you right now. All right, cool.
I do.
You do? Okay. So they'll appear on here, and you just use the arrow key will be forwards.
And those are already ready to go.
Those are already ready to go. We might just about be able to fit it there, but we don't want to break them. I don't know.
Does that work? Is that okay? Yeah, as long as it's not blocking.
Yeah.
Is that fine? Okay.
Are you gonna push the button?
No, I was gonna let you stand here and do that part. So I'll stay on this side, you stand on that side.
Okay.
I'll let you
Like over a bit.
first. Yeah.
That works.
Perfect.
If you want to rest it now, that's fine.
Okay.
Yeah.
Yeah, we can do that.
Do my best not to knock it over.
Thank
Quite
you.
clumsy,
Okay.
but-
You're okay with me leaving it for now.
Absolutely.
Okay.
Absolutely. Here we go.
Sounds good. Thank
Wonderful.
you.
Thank you. See you in a minute. Okay, fantastic. Thank you for letting me do that. Right. Good morning. So we're going to start on with our next session. Before that, I have one quick announcement. In your program, if you look here, you will see a QR code in the bottom right corner. If you have photos and you scan that, you can send the photos to the link on this, and then we'll be able to see them and be able to share photos of the conference together. Leah has asked me to remind you to only send appropriate photos. I'll let you interpret that, particularly with the nights out coming tonight. It is with great pleasure that I invite our next family up to the stage. I'd like to welcome up Ali and Brian and Bennett. Trying to get your slides up, but not having much joy. Oh, there we go. Great.
Hello, my name is Brian Bullard, and this is my wife, Allie, and our 3-year-old son, Boston, our 15-year-old, Junie, and our almost 2-year-old SCN2A child, Bennett, right here.
Hey.
It is really crazy. It's really crazy to us that we are even here right now. We just got our diagnosis 2 months ago. So this is all like. So we just got this diagnosis 2 months ago. This is all very new to us, and many of our friends and even family members still don't know about SCN2A or Bennett's diagnosis at all. And so telling this story is still very new to us. Before we go into Bennett's story, I just want to say that it has really meant a lot to us to be here with all of you. These 2 months have been really scary, as many of you know, and full of fear. And so being here has really meant a lot. And seeing how much love you all have for your children and the sacrifices that you make for your kids and all the hard work that's being done by researchers and medical professionals, it has inspired us to face all of this with bravery. Even, yesterday, first day of the conference, it was my duty to begin on Kid Watch. And so I took the boys to the toy room. and a little bit of anxiety in me going in there and just seeing other people and wondering, like, am I going to talk to people? Am I just going to sit there? You know, what is this going to look like? And just immediately, there were 5 or 6 dads in there that immediately started talking to me, immediately asking me questions, sharing their stories, and wrangling at the same time, and just so y'all know, like, there are a lot of dads here that are really kicking butt right now. There really are. Moms, you already kick butt, but the dads are really, as a dad myself, it's been really encouraging to me personally to see them and all the hard work that they're doing. And it makes me want to do the same. We're very thankful for all of you sharing your stories and sharing with us your experiences and welcoming us with open arms into this community. And we're really excited to have this community in our lives now, and all of you. So without further ado, I'm going to let Allie share more about Bennett's story and introduce you.
Before I do, I also just want to say thank you to Jenny Berg for sitting and taking the time to listen to our story. She really helped organize our thoughts. We've just kind of been all over the place with our thinking lately. And so we appreciate you doing that and writing that out for us. In addition to our immediate family that we also brought with us my mom and her mom, my grandma, who we lovingly refer to as Granby and Juju. They are 2 of our biggest supporters. And so we just are really appreciative of them flying here from Texas to be with us. So thank you guys for coming. Now on to Bennett. So he started out pretty typical as far as his development goes until around 6 months of age. He's always been a pretty chill and calm baby, and so we weren't overly concerned when he still wasn't sitting up at 6 months. But when at 9 months, he was still very floppy, not able to sit up on his own. It got our pediatrician's attention enough to act. She ordered PT, OT, and speech, and a neuro referral. Our neurologist thought Bennett was just taking his time, and we did too, but he agreed to do genetic testing. Insurance denied it, of course, and the battle was on to get it funded and start the long wait for results. 10 months later, we finally have results via MyChart in the form of a screenshot of the first page of the genetic report. I was sitting in our living room and the notification came up on my phone with the results that we had been waiting for. So of course I'm opening it up right away and I see SCN2A and I'm going, okay, what does this mean? And my first text was to my mom. She's a pediatrician in Texas. And so I thought she'll know. And I said, can you please dissect this for me? And she said, I've never heard of this. And so she starts looking, we start looking. And the first 48 hours after receiving that diagnosis were just really dark and scary. There was an all-consuming frenzy to learn about SCN2A related disorders as we began to mourn, grieving the loss of the life we had imagined for Bennett. In my mom's research and digging, she found the family's SCN2A website. We were very thankful to find this connection. We were also overwhelmed by the number of potential comorbidities, but glad to have found an informative resource, and it turns out a very welcoming community. With minimum explanation from our MyChart report and a genetic counseling appointment waitlist of a year, we pushed back and miraculously slid in on a cancellation the following week. It's amazing what you can do when your neuro will call over and get you in. The genetic counselor was very knowledgeable and did a great job simplifying the information for us. The geneticist stressed that he couldn't really say what the future would look like for Bennett, but he did know 3 things. He has loss of function, he has a frame shift mutation, and a 30% increased likelihood of having seizures. That last fact is our biggest fear. After hearing that, it created a lot of worry and loss of sleep in the first couple of weeks. We were just really worried that Bennett might have a seizure in the middle of the night. And what if we didn't see it and it went without notice? And so that kept us up at night for a good bit. In our search for answers, though, we found a grant from the Danny Did Foundation. to get a seizure monitor, which gave us some peace of mind so we could sleep better. It's still early and every day is different, but there are good and hopeful days now along with the hard ones. In our struggle to find answers, we said yes to everything that came our way, including this conference. We have a son named Boston, so when we heard it was here, of course, we had to come. It's really hard to find people who understand exactly what you're going through. But because of this community, we feel rare, but we don't feel alone. The immediate impact of the diagnosis was to increase current therapies. We've discussed a possible autism diagnosis, but we're waiting until he's a little bit older to further pursue testing on that. He's doing well. He's 22 months old now and he is making progress. He can pull himself up. He's cruising a little bit. He's babbling, trying some sign language, but it is tough to watch his frustration in communicating. For our family, a broader impact of this journey, by the grace of God, has been to push through the heavy and grieving stage where fear, worry, and what ifs are dominant to a place of hope, love, and an ability to look at life in a different way. To be more present with all of our children and appreciate them for who they are, not what they can or cannot do. Our lens on life has shifted and evolved in many ways. We are looking at things and people differently, and now have a little more grace and patience with others and ourselves. We believe that God made Bennett. We do not believe that God created SCN2A, but we do believe that he made Bennett. And a sweet genetic counselor that is actually at this conference, I don't know if she's in the room, Katie Helbig, just reminded us that there are 19,999 other genes in Bennett's body. And this SCN2A piece, while significant, is a small part of the whole picture of Bennett. That was comforting and a good reminder for me. And our kids are awesome. They're sweet, they're fun, they have interest, and all of our kids are awesome. And they are people and have a purpose in life just like we do. Thank you again for welcoming us into this community. And we just really look forward to continuing to do life with all of you.
Thank you so much. We heard from Berg this morning about how frequent cortical visual impairment was as a comorbid diagnosis. In the early onset group, it was 60% of children diagnosed. And so with that in mind, I'd like to welcome our next two guests together, Emily Cantillon and Lacey Smith, both from the Perkins School of the Blind, based here in Boston, who are going to talk to us more about cortical visual impairment.
Hello, everyone, and thank you so much for having us. As it said, we're from Perkins School for the Blind, and we're here to give you a foundational overview of CVI. As we heard, it's so impactful for our students and children. Sorry, as a teacher of the visually impaired, I'm going to use students a little bit. My apologies. But we'll give you an overview, and in our next session, if anything resonates with you, we're going to discuss what to do about advocacy for CVI. But first, our world is designed for us to visually process it. Things can be color-coded, grouped, and organized. But even when everything is organized, there's still things that trip up our visual system. Optical illusions. Maybe you're seeing a man looking straight on in the image presented. Maybe you're seeing a peripheral. Maybe you're seeing neither. When things are complex, even for individuals with perfect vision and perfect processing, things can be hard. There are 3 owls in this complex picture of children, but they're hard to find. But if I highlight and circle them, your visual attention is drawn to them, and you're then able to find it. For our students and children with CVI, it's important to draw that attention, to see and learn how they learn and provide individual and appropriate accommodations. Because if our world had no accommodations and all of our text was capitalized with no spaces or punctuation, we couldn't read it. What if there was not even capitals? It would be so hard for us to just function and process what's around us if we didn't put in accommodations and adaptations for us to enhance our visual processing. So what happens when we see? Our image comes into our eyes. It is processed, focused on the retina, sent back, and we move about our day. But what if something isn't connecting? Cortical cerebral visual impairment is a brain-based visual impairment that results from damage to the visual system and can impact a student's visual attention, recognition, understanding, and the ability to interact with the world. But CVI is a spectrum, and it's an umbrella term, and each student and child is impacted differently. There are not countless, but almost countless associated causes and conditions with CVI, as we learned today. But even with those, it's important to understand that development is not linear, it's not predictable, and that it happens and it adapts. The importance is neuroplasticity as well. We cannot predict the growth and the processing, but what we can do is identify opportunities and experiences that will help that development and work on growing that visual memory bank. So just kind of some tidbits. Our own contrast acuity doesn't fully develop till 8 years old, motion perception at age 12, and facial perception at age 21. We are always changing, we are always growing, and that is the same for our students and children. In this image by Dr. Maireade, we have a control brain, which is someone who is not impacted by CVI and CVI. What you see in this image is a decrease in connection between how the brain is communicating with itself. Through this decreased connection, the areas of brain that process visual information are not able to talk. They can't say, oh, I'm seeing a green apple, or this is really busy, where's my favorite toy? And because of that decreased connection, it impacts our student and children's able to access the world. This connection, it's previously been split up by dorsal and ventral stream, but these really talk a lot to each other. And really it's that disconnect, that decreasing connectivity between them that impacts the dorsal stream's processing of location, movement, and how the ventral stream takes that and says, oh, the color, the texture, the detail, and works that into what that image really is. So that connection, you're going to see how important that is. So I can see a lot of you are looking at the screen right now. That's great. Don't. Please look at me up here, tall person on the stage. And what you're going to do, it's going to be quick. Don't look at the screens. I'm going to show something. Just don't look. I'm looking, I got a lot of eyes, okay? What flashed? You can shout it out. Slides change. Any colors, shapes, textures? Awesome. Okay, cool. Would you be able to navigate that world? No. And for our students and our children who are using primarily their peripheral vision, they can't be expected to process that world either. Because that was the image. You had two individuals, you had a solid color, you had text that was big and bold, just how we say, you know, make the text big and bold, but you didn't process it. Yes, I was mean. It was a little quick. But that's how important that connectivity and making sure how we present to our children and students is individual to their needs. Because you experienced difficulty with color, shape, movement, fine details, all of that was impacted. So it's important to build on experiences, create memories, build on emotions and connections. And through that, there are some visual behaviors that are important.
So I'm going to talk more about the visual behaviors. At Perkins, there is a tool being developed called the Perkins Protocol, where we look at 16 visual behaviors, and I'm going to briefly explain each of them. This is the overall list. We also look at compensatories, like are they using auditory or tactile skills to really help them identify what's around them. So visual attention and visual recognition are kind of the big umbrella terms. So when we're looking at visual attention, can the child sustain contact on what's presented in front of them? What is their visual attention like? Are they visual? Or are they not interested in the world around them? And it varies from each child. Visual recognition is another thing. You know, just because you can see something doesn't mean that you're recognizing what it is. And that's something that we take a really deep look at to understand better how the child's using their vision again, and maybe what compensatory strategies are used to identify the object or the image. Emily showed you a great example of the spacing, just the text on the page, like we cannot read that. And for a lot of our students and children with CVI, spacing needs to be further apart, or just the way things are presented to our children. And then thinking about clutter. And if you think, like I look around this room right now, it looks highly cluttered because there's so many people, there's chairs, and it would be near impossible for somebody with CVI to navigate around the system. We also talk about form accessibility. Do they understand it as a whole, like as a dog, as an image of a dog, as an image of a cartoon dog, a realistic dog? Or can they understand in black and white? Do they need that color to support them? That's an area that we look at during our assessments. Access to people. How are our children identifying people? Is it by their voice? Is it by their hair color, their shape, their size? All of these things are considerations when we're thinking about our students. Do they have a favorite color? Maybe not, but are they drawn to color? Does color support where they're looking? Just as Emily showed in that example of the owl page with the circles, you could easily focus in once there was some color. We look at how motion impacts students, like can they understand slow motion, fast motion, you know, even thinking about like facial expressions. Can they understand emotions even because of the motion that happens in your face? When you're showing, you know, smiling, can they understand it still or not? Are they scared when you come up to them quickly? Impact of light. Do they need light to support their visual attention? Do they need light to support their visual recognition? Are they drawn to lights in the room, the windows? And then how really do we accommodate for that? You know, a lot of times we would say, hey, just position them with their back towards the light, or use light to help draw in their visual attention. And visual curiosity is something we look at is when a student enters a room, are they looking around? You know, for us, it's easy for us to see different things in their room, but for many of our students, it's limited, it's limited to, their curiosity is very limited. How long does it take to get their visual attention or for them to visually recognize something? That's always a big consideration, because we need to be able to wait them out so that they have the opportunity, because the processing is a lot harder. Visual fields is a big one, you know, like if I look around, I can see people on my left and right in front of me. Some visual fields are restricted, as you can see kind of in this image, in the top right. A lot of our students have lower field neglect, so they might trip on things in their lower field, their lower half. They might have a harder time navigating around when steps and different thresholds. Upper limb, can they reach while they're looking? Do they look away while they're reaching? Can they accurately place something on a shelf? There's so many considerations that go into really each area, and they overlap so much. Lower limb, again, you know, could be lower field neglect, but like some of the observations we've seen with some of our mobile students is that maybe they'll use the heel of their foot when they're walking down to kind of place their foot And there's all these different compensatory strategies that when we're observing students that we're able to find out. But again, this is like, think about curbs and anything in the lower field that just might not be seen and how much harder it can be. Sensory integration is a big one. Can you look and listen, or can you tolerate a noisy, busy place? Or are these when the CVI meltdowns occur because it's just too loud? And is it a good learning environment? And visual fatigue is huge. A lot of times our kids need breaks built into their days because it is exhausting for them to look and to process and to recognize and to do as asked of them throughout their school day. And I've probably never gone through the visual behaviors that quick, but you can join the CVI Now Parents Facebook page if you haven't already. We also put flyers out on the table. We have an upcoming conference next June. There's a lot of resources. And that is it for this presentation.
Yeah.
Thank you. We're gonna, Emily and I are gonna switch off a little bit in this one as well. So one of the things, I am a TBI, but I'm also a rare parent. So I get the journey to, my daughter is very similar to this organization, her diagnoses, I would say. So I'm going to talk a little bit about advocacy. Emily is going to talk about educational advocacy. I'm going to talk a little bit about my specific journey of advocating for her medical and kind of her educational piece. So we're always advocating, I think, as parents, and I'm going to speak as one of you because I really, really am. So I think about how much medical advocacy I've done, educational, and then just really for supports. And I'm from Massachusetts, so from Massachusetts supports from friends and family. Each of our advocacy journeys look different. There's definitely not one size fits all because our children are all different. Even if they share the same diagnoses, they're still very different. Our priorities are different as families, and that's what makes our journey so much different. So no, step by step, we just kind of have to figure it out. And I think our heart's always in it because we want the best for our child. So we're going to look at some like the law about education and then how to kind of advocate for a more accessible education for your child and medical, really. I love this quote. It's our journey is not linear, and my daughter's 12 now, so we do circle through phase after phase after phase. You know, along the way we've gained diagnoses, and it's been really, you know, it's been a journey. It's a lot of what I think about every day. So I'm going to give you an example of just one way that I find that we can start advocating when we talk to anybody about our kid. So I'm going to present to you child A. Child A is vocal, loves water sports, loves food, musical, in the sixth grade, clear preferences, social, loves to be around people. She's stylish and she's persistent. So when I describe this child to you, what kind of future do you think that she might have? Don't be afraid. Do you think that she's going to have a lot of friends, go to a good school? Maybe she's in some activities that are after school, or what? Say that again.
She's going to be an actress.
Oh, an actress. Yeah, maybe. Yeah. I mean, they're all very positive. And then I could describe to you child B. Child B is nonverbal, non-ambulatory, has feeding difficulties, has difficulty accessing a variety of toys in their environment in general. The learning is non-academic. child is laid back, misses social opportunities, parents choose her clothing, and she is consistently inconsistent. So when I describe that child, do you think she's going to have a bright future compared to child A? Yeah, so I think it's important to always choose our words about how we talk about our children, because we want them viewed in the same positive light that we see them in. And it starts with us. So really, this is my daughter, Savannah is her name. And these both describe her. So, and here's her overwhelming kind of care map. It's very overwhelming. This is what we do to keep things going in the right direction for her. But I'm going to talk a little bit more at the moment about kind of her school journey, educational journey. We live in Salem, and we, from the time she turned 3 and transitioned from an IFSP to an IEP, we knew that she would need different supports than probably what the school was going to offer her. So we fought for out of district placement and received it. So she went to a collaborative and she received services there. And then she started having a lot of self-injury because why? Her sensory environment was too overwhelming for her. So she would hit her head and she would try to say, I don't like this. So then we were able to get out of district placement again. And we're very blessed that she goes to Perkins School for the Blind. But that doesn't mean I haven't had to advocate for her services or her CVI along the way. She's had different team members. She's also changed because she does have epilepsy as one of her diagnoses, and she did not develop that until she was 7. And, you know, there's times where that just really impacts who she is due to medication, due to her seizures. And so it's just been a constant journey of what's working best for Savannah. She's always been a multisensory learner. We've always known that. But right now, the visual piece is just too much for her. There's a point in time where she did use her vision a little bit more, but right now we want to involve auditory, tactile, and vision to really support her CVI and her needs. And it is our children's rights to education. And Emily's going to go a little bit more into that.
Thank you, Lacey. So when we think of how to advocate for our students and children, it's important to think of, what does blindness mean? Blindness in every state, even in this country, means something different. Even at the earliest age, there isn't consistent early vision screenings for preschool age children. Some states have them, some states don't. It's also a controversial topic in itself of early vision screening. But just in that sense, there's inconsistencies. Even with how the government describes blindness is different. Through the Social Security Act, it is very clinical. It's based on acuity of 20/200, degree of vision field, and having that for at least 12 months or longer. Whereas the IDEA is a bit more broad, saying that any impairment that adversely affects educational performance of a child, both partially sighted and no light perception, it qualifies as a visual impairment. That is then expanded to say all visual impairments, blindness, sighted, anything that significantly impacts that visual access. So under this broad definition of IDEA, any decrease that impacts your child's access visually to the environment falls under a visual impairment. So with that, we want to keep in mind free, appropriate public education and how visual impairment and CVI falls into that. First, there's a decreased to almost no incidental learning due to decreased visual access of the environment. If a student is in a classroom They're not able to look around and take in the graphics on the wall, their peers' facial expressions. Due to that decrease, their access to the environment and educational experience is different. They must be taught in a way that matches their learning needs. As Lacey mentioned, for students with CVI, that fluctuates. One activity might be vision-based, one might be tactile-based. That needs to fluctuate, and those methods of learning changes. And also, it looks different across different settings. But vision eligibility for our students isn't cohesive, and the educational standard and the medical standard, they don't always align. If you have a medical diagnosis of CVI, that doesn't mean you directly get certain educational qualifications and accommodations. Just as if a teacher of the visually impaired evaluates your child and suspects CVI, that doesn't automatically mean a medical diagnosis. There is this disconnect. Educational approach takes in from a teacher of the visually impaired, team approach through vision evaluations. Each state is different. There is no direct process to getting a referral, what evaluations are used, and no standard way of the team handling that. And there is no standard way of the medical communicating those to the educational as well. But one thing that is consistent is that if there is a medical diagnosis, your child would hopefully be registered under your state's Commission for the Blind. Here in Massachusetts, CVI can qualify as functionally legally blind, meaning their access to the visual world limits their access enough to qualify for Mass Commission for the Blind, and there are some benefits to that. A vision assessment is done by a certified teacher of the visually impaired, looking at a functional vision assessment, learning media assessment, looking at the expanded core, and looking at a CVI evaluation. Those not come and go, but there's different assessments within those, and there isn't a standard, but those really should be what's done if you think that what we previously said recognizes and you see those behaviors in your child. Low incidence does not mean low priority. This is huge. I've had to fight for my students to have access and accommodations that meet their visual needs. You have to fight every day, and that advocacy really is individual to your child, but know that access to an environment that meets their sensory needs is key. It's their right. And that a multi-sensory approach to learning is also key because the world is complex. Vision might not always be a consistent access mode for them. And those compensatory skills like using tactile, using auditory really do need to be incorporated to ensure holistic access. That can also be done through the expanded core curriculum, but for an individual with a visual impairment, including CVI, the expanded core curriculum should be embedded throughout the student's day. It is a curriculum that supplements the materials and opportunities that the student is missed due to decreased visual access. And with that, there is the medical side.
Sorry. I was going to say too, with the advocating again with the expanded core curriculum, one of the areas I always like to think about is social skills, because my daughter is nonverbal, but that doesn't mean that she shouldn't have the same social opportunity as her peers. But I'm going to dive a little bit into kind of how I've medically advocated for my daughter. She was I would say a lucky one that got a CVI diagnosis at 8 months. So I didn't have to fight as hard for that. But I know that many families, especially when they have a rare disease and it's maybe misunderstood or not understood enough, they might have to advocate harder. Medical diagnosis is how CVI is identified. I mean, TVI will help identify it, but TVIs do not diagnose. But part of my journey in the medical field is knowing that I've really had an option. I'm not limited to the doctor that I started with. And the biggest example I have from this one is actually my daughter's genetics journey. So she's about one of 120 kids with Ogden syndrome that are identified in the world. And when we were trying to find a genetic diagnosis, we did microarray in the NICU. That didn't come back with anything. So then I continued to be followed by the NICU doctor. And I just had a hard time because she treated me like I was a child, even though I was now a new mother. So then I found somebody else, and he gave me a piece of paper that gave a life-limiting diagnosis for my daughter for a genetic condition she doesn't even have. So I said, no way, I'm going back to him. So then I sought out another one, really loved him, thought he was great, hard to get in contact with. I'm not going to keep chasing these appointments when I have a gazillion other things to do. And I know that may sound like I was giving up, but I also thought, if I can't get this appointment easy enough to understand what is going on with my daughter, then I need to go elsewhere. So I went back to the hospital, MDH, where I was working, and found a new one. And she suggested we do the whole exome sequencing, which is how my daughter was identified. And it got to a point to where I was paying for appointments and educating her about my daughter's disease, which I'm sure many of you probably feel in this room. Like, I should not be the expert. I don't want to be the expert on it. So then I went back to the doctor that handed me that piece of paper that limited my daughter's life, because he works with rare populations. So it's just, and when I went back, I had to have that courage to say, hey, we were here when she was about 2 years old. This is what you told me at the time. I cried in my car, and that's why we haven't been back. And he had no idea that he'd ever even hurt me or my family during that time. So it's okay to shop around. We've shopped around a lot. Find the clinicians that believe in your child. So my daughter's pulmonologist, they did a little article on her, and they said the common goals and collaboration between us and Savannah's family make her care a joy. Like, find that doctor, her care a joy. Like, that is the biggest thing for me, is like people that get down on her level, talk to her, like when she's present in the room, make sure that people are doing that for your children. They deserve it. Our GI also said, as a provider, I want to keep focus on Savannah's eating for joy and for her parents' joy. It's been wonderful to see her parents prepare food, enjoy it together, and feed Savannah. It's also important to preserve that joy and quality of life as a doctor. And then he also goes on to say, this is a journey we embark on together. And I think that's just key. Whether you're fighting for educational rights or medical rights, you are the biggest team player that besides your child, and you just have to keep that in mind. Your decisions matter. And, you know, I know it doesn't always feel that way, but I just think it's just so important for us to realize that. As mentioned earlier, CVI is a high diagnosis even in your population of children. It is in ours too. We don't know the exact numbers, but there's some of our kiddos are diagnosed with CVI and some of them aren't. And it is common for neurodevelopmental conditions. So the evaluation for CVI is an ongoing process, kind of as I mentioned in Savannah's education. She was more visual at one time than she currently is. So thinking about what changes, having that close, open communication with family or with your team, and be prepared. Share medical reports with your school team and share educational reports with your medical team so that everybody can really get to know your child as a whole. And again, you're always entitled to a second opinion. And that's it.
Great. Thank you very much. Our next talk is about accessing resources in your state. Knowledge is power. I'd like to invite Pat Cameron up to the stage. As she's coming up, a reminder that after lunch at 2 o'clock, there is a session which has described itself as being optional, that self-care is not selfish. I would point out the deep irony of not going to that session, and therefore it is not optional, and you should all attend. I'll hand over to Pat Cameron.
Thank you all. And it's been a pleasure to be here with you these last 3 days. I've been staffing the table for the Federation for Children with Special Needs, and that's where I'm from. And I hope to extend some resources that you can take back to your states and to wherever you are living. So a little bit about who we are. And the Federation for Children with Special Needs is a federally funded program, a parent center. Every state has one. And you can find out information and support and assistance in piggybacking on what the staff from Perkins just presented, is to know your rights, to know your child's rights, to be able to navigate both the education system and the healthcare system, so that your family can have the best quality of life possible and be included in the community and have the resources available to you. My specific program is called Family Ties. And here in Massachusetts, we're funded by the Department of Public Health Early Intervention. And we help connect families whose young children haven't met their milestones or have been born with a disability and need early intervention, and we connect them. We also run a parent-to-parent program, and I'll talk about that in a bit more in a minute. The important piece to know is we're also all parents. So my child just turned 40 this week, and has vision, hearing, and an intellectual disability as well. But we all wear multiple hats. And I think, as you progress both within your homes, your families, it'll be obvious when those hats come on and off. So today I really want to talk about what is it you're looking for? I've heard wonderful, wonderful stories about just how overwhelming this situation is and how it can be for your family, and the importance of just sort of prioritizing. Where can you find resources, and how do you organize all of that? So what are you looking for? Think about, what is it? Is it that your child is just born, just been diagnosed? You've got a new living situation, you're moving, you're looking for a new pediatrician. What is it that you're looking for? And how do you want to learn more? Because knowledge is power. As I said, we are a federally funded parent center, and every state has one. This is the website where you can search for your own parent center. I was just talking with a parent who's from another state and didn't have a clue that there was a parent center. And so we are probably a well-kept secret, sadly, but I would love for you to search out your parent center. There are states with one. Massachusetts has one, but New York has 5. And so, it all depends on how they applied to the federal government. As I said, we are funded by OSEP, and we are charged. Every parent center is charged to do this, to be working with families with infants all the way up through age 26. And I would add beyond, because we don't turn anybody away. If somebody calls and they're struggling with their 45-year-old, we're going to try and help connect them to the local resources that can help them with whether it's family support, adult services, and so forth. Helping parents participate effectively in their children's education and development. And I would include healthcare as well. And then we also partner with professionals so that we can help them understand what it is to be a family and the challenges of raising a child with a disability. So that, you know, is the speaker that just was on talking about, you know, making changes, making that connection, finding that professional who understands and who advocates and who has a similar perspective on quality of life. Parent centers help you understand what the local, state, and federal requirements are around special education. IDEA, the Individuals with Disabilities Education Act, was passed as a federal legislation, and then states have the option to build on that. Every state has that as their foundation, whether it's the Americans with Disabilities Act, the Civil Rights 504, Rehabilitation Act. Those are all foundational, and then states have the opportunity to build upon. They can't decrease, but they can enhance what's available for your sons and daughters. And then you have local. The local school boards, the local school districts, and so forth can decide whether they're going to be providing a service or contracting out. We have a program at the Federation called School Finder, and we help families identify the ideal school for their sons and daughters. There are international resources. So I know there's a family here that introduced themselves the other day from Dubai. If you are an American citizen and you are living abroad, the US Department of State offers a glossary a directory, of schools offering supports for children with special needs. And so regardless of where you live, there's something out there. And then I came across this particular organization called World Family and Education. And they have a wonderful, wonderful website, which offers a breadth of resources in countries around the world. And so I would encourage you to check this one out as well. Here in Massachusetts, we offer a parent-to-parent program. I know I've heard families talk this week about how valuable it is to talk with another family who's been there, who's done something you're encountering or struggling with. And here in Massachusetts, we have a trained cadre of families who are trained in active listening, who can really understand and empathize with what a family is going through and can offer not advice, not prescriptions, but emotional support, to know, to listen, and to be able to say, I hear you. Have you thought about this? And ask those probing questions that might get you over the hump of whatever issue you're dealing with right now. And Massachusetts is fortunate to be also connected with Parent to Parent USA. Now, this map shows that we're almost in every state, but not quite. But P2P USA would be very interested in, if you live in one of these states that's colored gray here, to be able to open up a P2P program in your state, because the mission is to go nationwide, and we'd really love to be able to do that. We're an alliance member with P2P USA, so if we don't have somebody in our state in Massachusetts, we can do a national search. So for children with just unique circumstances and unique diagnoses, we can do a national search and try and match families up. Then the whole idea of once you get all this information, it's so necessary to be organized and to be thinking about what systems you can put in place on this journey to be organized, to have all that knowledge and information, to have it in an organized fashion so that when you go into a meeting or you go to a medical appointment, things are right there. When my daughter was growing up, we didn't have technology. And so you literally had this 3-ring binder that you would bring, picture on the front, artwork and so forth, and you would plop it on the table and say, this is who we're talking about. I want you to meet my daughter. I don't want you to meet an education plan, a diagnosis, a test result. I want you to meet my daughter. And so when she was young and not attending her meetings, that was a great message because it centered everybody. Nowadays, you can put it all on your computer and you can take that laptop or tablet, pop it open, the photographs are right there. It shows your child in the context of their community, in the context of their family, in the context of your faith community. And it just is a nice holistic view of who your child is. And then you can grab, if somebody says, well, what medications is she currently taking? There it is. You can pull a file, you can open a file on your computer, you can pull something out of the binder and so forth. And it gives you confidence to be able to come in and say, yes, I am the expert on my child. You're just a participating person on this team, but I'm the expert. So we really want to encourage you to go from piles to files, and whatever that looks like for you. So I want to just take a moment to be able to just open this up because I am not the holder of all knowledge. You guys have been doing this in your towns, in your states, and in your communities. And I want to open it up to somebody. If you've got an idea of a resource that you've been able to identify that you want to share with others, you can either write it on the note cards that are on your tables, or feel free to shout it out.
There's a list of all of these grants that are available to special families, but it's like hundreds of them, and you have to go through it and determine which ones you're eligible for and which ones you're not. I would love something that narrowed it down, or you could just put in there something like
keywords, yeah.
And it doesn't pop up ones for cancer. And so then you can go through it that way. But I found that just the support groups online for local areas are really helpful with that. They share grants that they've been able to receive or waiver programs that nobody tells you about, and you have to push and advocate for.
Absolutely, absolutely. In Massachusetts, we put out a directory of resources, and we have one on the table there. Help yourself. They do have some national information as well, but it's also something, and I would encourage you to look at all the materials, take it back to your states and say, hey, Massachusetts Parent Center does this. Can we do this here? And so, take my business card. I'm happy to speak with anybody about how you might be able to replicate. But to Leah's point, there are funding resources in the directory as well. Yes.
So I volunteer as well with the special needs in my city. I'm from California. So to be honest, I'm not sure if they do it throughout the US, but I did hear a few other states that do it. But they are a good resource and they help you through educational, medical, anything like the regional centers do. But they also do fun stuff for the kids and for the parents. And what's it called? Special needs in my city.
Special needs in my city.
Yeah.
That's cool.
Yeah, so I part of that. I do a lot of volunteer, but that's one of them. And it is like the regional center because there's a lot of workers at the regional center that aren't putting out resources to people unless you try to contact them. I have a good one, but some of my other friends said they don't have regional center people that actually are telling them things. So, but special needs my city, anyone can be part of, and the one in California that we do, we actually have some from overseas that join in on the Zoom visits, the fourth Thursday of every month. And we have a doctor that comes on and we do like a group talk about whatever questions or whatever the subject is, and it's really good.
That's a great idea. That's a great idea. Other thoughts, other resources?
I know in Baton Rouge, and again, I don't know if this is all over or whatever, from Louisiana, but there's a organization called Families Helping Families. And they do newsletters, they do seminars, they have like different activities each month to get people with special needs community connected that might have to unite or, different little things like that.
Yeah, Families Helping Families. Terrific, terrific. Yeah, every state also has what's called their F2F, which is family to family. So I'm glad you said that because that's what it reminded me of. And they're funded by HRSA, which is the health organization, and and maternal child health. They provide a network of families who can help around healthcare issues. In Massachusetts, ours is located at our parent center and under the auspices of Family Voices. That's also another national organization that helps advocate for healthcare. And we have brochures at the table. And again, pick up anything you want and take it back to your states and see whether or not something similar exists. Other suggestions? Well, I want to thank you very much for including me this week. It's been absolutely wonderful meeting with so many of you, and good luck on your journeys. Thanks so much.
Could I invite Emily and Lacey up to the table here? And again, you know the drill. Fill in the questions, hand them in, and we will put them to the panelists. Sorry, I'm trying to move my room that way. There we go. I have a question on CVI as the questions come up. How well accepted is CVI as a concept? I know, sort of going back to when I was trained, mentioning there was something with a stigma associated with, or it wasn't necessarily believed to be a thing.
Yes.
Are we past that, or is that still a concern?
Educationally or medically?
Medically.
Ooh.
I think it's still a concern depending on where the professionals are. Honestly, I think there's a ton more kids that probably have CVI but have not been medically diagnosed because of the lack of understanding.
Yeah.
Yeah.
And is there any sort of like biological test, like an MRI or an EEG or anything like that which can pick it up, or is it still a clinical diagnosis?
Yeah, so right now it's still a clinical diagnosis, and it's really ebbed and flowed in the way that it is diagnosed.
Yeah.
I know Maireade and the Laboratory of Visual Neuroplasticity have been using fMRIs that kind of showcase what you saw on the screen, the connections. It's not feasible for everyone to have that. That's been a way, but it's also linked genetically as well. And that does not show up on a brain scan, MRI, CT, anything as well. So it's really a combination, observational, clinical, but there is no standard right now.
And when you see the image, that was the green picture
Yes.
of the brain on the left and
Yep.
the sort of unconnected brain on the right.
Correct.
Right. And so we've heard today that somewhere between 40 and 60% of children, depending which cut of our warriors, have a diagnosis of CVI. Are you surprised with that? Is that higher than other conditions, or does that seem appropriate for a genetic developmental disorder?
I would think it depends on the genetic disorder and why the causes of the genetics, but even just epilepsy alone, you're more at risk to have CVI, or
Right.
if you have any type of brain abnormality, you're more at risk to have CVI. So I think that there's still probably a multitude of rare diseases that have no idea that their child is visually impaired because it hasn't been brought to their attention. And sometimes with these medically complex kids, that's not the first thing a parent is necessarily even looking at because they're just trying to keep their kid alive.
Right. Thank you. Continuing the CVI focus, what age is best to be evaluated for CVI, and who does this evaluation?
Yeah. So I'm going to start, and then Lacey's going to take over from her experience. I think if you see any of the visual behaviors, visual characteristics in your child, in your student, as early as possible. As Lacey said, she had her daughter had a diagnosis at 8 months. The earlier you can get diagnosed, the earlier student child specific interventions can take place to help ensure access to the world. If there is any question,
of visual access and visual recognition, visual attention. I think bring it up to the medical professionals and as soon as possible. Or bring it up to your EI team. Lacey can kind of speak to that end because she is an EI TBI.
Yeah, so just a little background. So Savannah, my daughter, was diagnosed early because she checked boxes. She has PBL, she has hydrocephalus. This is before she was diagnosed with a rare disease at like 4.5. She had a stroke. And so all those three things, like if I see that when I was a teacher with the 0 to 3, if I saw that on somebody's history, I would immediately start suspecting that this child is at big risk for a CVI. So this is what we want to happen. We want more medicals to understand this. So there's an earlier referral and early intervention teams because, you know, when my daughter, I had no idea about vision impairment, not a clue, but I just attributed some of her visual differences to her hydrocephalus because they told me that she might have her eyes are in a sunsetting position, but I was sure that she could see because the way she would like open her mouth and look at the mirror and above in her swing. So as early as somebody can be identified, that's just better for neuroplasticity. I know that's a long answer. That's what I do.
Do your referrals tend to come from neurology or pediatrics or ophthalmology?
Referrals can come from EI teams even, or parents, if you have suspicion.
EI team?
Early intervention teams. Or a parent that's suspicious that their child might have it. It could come from a neurologist. It could come from a pediatrician. It could come from an ophthalmologist. It's just like sometimes early on, these kids aren't even seen by an ophthalmologist yet because they have no concerns at the time. If that makes sense.
Absolutely. Pat, a question for you. Which organizations can help with insurance claims?
The quagmire that exists within insurance is such a challenge. The F2Fs, the family to family and the family voices can really help navigate particularly health insurance because here in Massachusetts, we have different levels of Mass Health, which is the Medicaid program here in Massachusetts. And you really need to be advocating for specifically what your child needs. And they also offer here, and this may be relevant in your state as well, if you have private insurance and your child may qualify for Mass Health because of their disability, you can get supplemental assistance in helping pay your family plan. And so again, brochure is over at the table, help yourself to any of the the F2F family voices. And you can take that back and find out whether your state has the same instances as well. Here and parent centers should be well versed in healthcare as well and health insurances. Massachusetts has what they call enrollment centers, and you can literally walk in and talk to somebody. If trying to do the research online, trying to fill out the applications all by yourself is overwhelming, you can get help. And so I strongly suggest, take a look within your state, find out if there are enrollment centers. I've used 2 different enrollment centers from, moving around here in Massachusetts. Both have been incredibly helpful. And they have staff speaking other languages as well. So if language is an access, they should be able to accommodate you.
Great, thank you. Are there any more questions? All right. Well, you've done a fantastic job. You answered everything in your talks, plus a few extra. Big round of applause for our panel. Thank you very much. I'm going to hand over to the wonderful Leah.
Thank you so much. Okay, who's ready for lunch? It's almost time. So this conference has flown by as usual. I wish we could all live with each other, like in a compound, so we could all just support each other every day, all day, every single day of the year, because going home, it feels kind of lonely after spending days with my family here.
So it's been amazing to see all of you I've met before and spending time with the coolest kids in the whole entire world, and finally getting to meet those of you that I haven't met in person this year. We hope that you've all enjoyed your time. You've learned a lot, you made friends, but most importantly, that you go home feeling empowered to advocate for your child for the best possible life, the best care that they can get. There are so many ways for you to get involved with the foundation, and we need all of you to get involved. I'm going to make one ask. We're going to send an email after the conference. It's going to be to sign up for your Warrior Challenge team. We'd really like 100% participation this year for each family to create your team. Doesn't matter where you live, you can create a team, and it's just a virtual walk. You can organize your little walk in your little area. I have like 20 people in my neighborhood that walk with me. And it's a fundraiser. It's also an awareness raiser, and we've done really well with it in the past. That will fund more scholarships for more families to travel to conferences like this. And as you know, it's really important. So lunch will be served again out here and by the pool. You're welcome to eat in here or by the pool, but we do have to be out of here at 2. We're going to take a 4-hour break. In that break time, I think you may have already seen the notice that we had to cancel first aid CPR. So I'm sorry about that, but we will have that self-care is not selfish. And we really do encourage you to come. There will be adult beverages for adults. So we ask that your kids maybe play in the playroom, and we will be self-caring. To the scientists, the clinicians, and the other professionals that are still left in the room, we just want to thank you. Thank you so much for being here to teach us and allowing us to teach you. Your work inspires us and lights a fire under us to keep going, even on our really dark and really hard days. Instructions for the rest of the day. So after lunch, I've already told you about the self-care. And then at 6 p.m., we're going to be back in here. This room will look very different. This will all be gone. There'll be a dance floor, and it's our warrior celebration dinner. Tonight is for our warriors. So we will be celebrating. We will be dancing. There will be an open bar. Wear your t-shirts. Today's t-shirt day. And that's it. Thank you guys so much.
Oh, I should. Thank you. Pickle River Way.
He said it takes 3 things. She has 2 of 3.
So we went upstairs and she was like, no, 0 week so every single category yeah. So what I think that yes. Right. Right. Okay, yeah, I would love to be like, you know, just get it done and share. Yeah. I understand. Right. Yeah. It's always an accident. Yeah, that's why it's just taking everything in.
It sounds a little,
I just saw your
Like their headlighting.
She's not out there.
Pharmaceutical grade lead is. Yeah. Bruce Springsteen. Oh, there is that. They're always Oh, really? Well, it's crap for kids. I can see how no, it's funny because they had a sign that says they were stopping people at the door to bring no, it's actually pretty research-based. Oh, no. Heard of it. It's, yeah. I'm speaking. Oh no. No, I really don't. The registration and it's super cheap. But it's very research. It's not. It's mostly research. I don't know. Well, what you're talking about think those people know the function. Yeah, you're talking about. We are what I use. I was like, yeah, that's clear. What kind of clear? Whatever's not green. That's what's there. Yeah, it is whatever's right. Yeah. There might be a process. Actually, one of the guys was saying so there might be a cedar rider. That's good. They tried it. Like what culture exercise. Yeah. But they saw that. Yeah. Yeah, my colleague. Yeah, I think so. You gotta buy it. What are we doing? I have to pay right now. 33 I'll have a text soon. But it's a super exciting project. Yeah. But it's like The first time I tried it, my last row. So recently I tried it. And everything goes. 4 hours. Half the dishes were Thanksgiving. And then I changed media, and the other half also became a little bit. Well, we used this for the first. Yeah. Young guy. Yeah. Right now, yeah, but so what I got start on I have that. Yeah, so I asked for that's like I'll take over. It's a specter. I'm gonna check out there's a minus 80 for liquid nitrogen already. A lot of stuff. It's not going back. Fisher cutting. It's like no, I was just thinking I feel like I invited like the bands that I like as like every episode. Instead of going all we had the Fisher brand oil. It's like a and then I think the next one. I think Yeah, I think the secret patch is technically on. Yeah. Start clean people know how to run it. Yeah. Usually I think usually they just be like, we want to bring it up right now. Do they have some skill? Comment for oh, you know, we have one press. No, we have two presses. Although it happens that they went like in the background. Because he just gets sidetracked. People they actually worked it out. So I was like, I was getting good. I'd love to get working. So I've got like it's not too but like my side, so it's a shirt. That's what I'm saying. Yeah, I think so. Yeah. No, I actually do. It's very good. Just like I think what I did. Like Yeah. So is it more about pharmacology? Yeah, I remember when I cracked it. Finally figured out. Well, they're not like like the last show. Oh, that sounds really good. It's better than the usual. Yeah. My main criticism is that it's just very like the pharma, stuff. Trying to, and like he's already doing off the experience, you get to like see the big picture, like how like the experience was he knows I think it's cool like from start to finish, like through, I don't think this thing. So yeah, thank you. Like how much is this cost on eBay? Yeah, if everything's just like task. I don't know how to work with kids, but I don't think get a verb. Get a laser roller. Like that's under like YouTube out. Yeah. Oh gosh. Yeah. 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 But like these floors haven't changed in 30 years. They literally just put a screen brand new. They put the LED on instead of like the black and white, the amber color. It looks exactly like what I used in grad school, but as a fancy screen. No, well, the first time I did it, yeah, just the midst of it. But we have a the one I heard is but if they wanted to. Yeah, I'm gonna go meet my boss.
Okay, yeah, we're gonna leave it as there, but everything else we take out, so we're worth it. And they are spraying. I really appreciate it. I really
I think there's some good ones in the bunch. Yes. That's all you want to see. Yeah, it's really good. Yeah. And then that's Berg. Real cases. They actually do. That's not, that's so we
They're moving a stage. The DJ is probably going to set up back here somewhere. The dance floor is literally going to be in this kind of vicinity, which means
How do you use the edge of the stage as a guide?
I would assume. So my hope is to have most of the hanging things in this area. So it means that like the command hook's going to be there, here, and here, going to that center area back here.
Yeah, you can probably.
So it's kind of going to be like.
Probably do one on each side of this.
If we have enough length.
So
I want to do the two on that side first, like an A.
Well, let's call it 50 feet. So 50, 100, 50, 200, 50. Yeah, I mean, you get 900 feet. No worries.
So, and then most of the hanging bits will just be kind of, so if all the lines are going, they'll just be on this kind of area. Okay. So it might be an odd line shape, but like,
yeah, it's about.
It's just starkly stuck in there, but they'll be, I haven't pulled them out. I think they're about this long.
Okay, so I just get them up as high as.
So as high as we can.
It'll be down probably here because it's stage, but I'll just I'll get some put up here.
So
The stage won't be here. There won't be.
They're going to be moving the stage.
So there won't be any stage. Like if I.
So even if you were to just reach up right now, almost.
Yeah. Yeah, that's what I'm thinking.
Well, Pop was there. So you're going to go. Dr. Bender's waiting for you. No, I want. Oh, so then just wait. Because those things are, I'm not going. So Cora, he's waiting for you, which means I'm going to give you some money to spend at the zoo tomorrow. Henry and Dominic have already done theirs. They did awesome. It literally took 5 minutes. Mommy's working right now.
We're helping for it. If you don't want to do it, you don't have to. No, I'm helping too. We got a lot to do. I'm not doing it. Okay, you don't have to do it. It's fine. It's not a big deal.
Fine.
So where are you gonna go?
So I think all my men are gonna be upstairs. Huh? I'm not going up there right now. I'm busy. So do you have those water stats? Do you not do that? Then you can sit. And then you're tired, so you got two options. You can go upstairs and have a nap, or you can sit and relax. I've heard you had a great time. Do not just walk in here. Just like here. This is my job. This is my job. You know what's up 10%? You don't see it now. And it will drop you off and make sure you want to drop it in or 4 or 5 in the hole.
so it's okay. Yeah.
I don't think that is even an alternative. I was talking to Josh about that. Yeah, that's what you were saying. I can double check. But I think we confirmed that with your client. Yeah, let me give them a call right now. Yeah, let me check in with confirm them. All right, back. Eric Ortega just mentioned that person where we were at on that conversation here. Yeah, where that was an option or with like Excel.
Hey, is it possible to get set later?
We asked, and they said there'd be two, but not there. Yeah.
study data from all sorts of other clients.
I want to spend the night outside.
How many tables are going in here?
Need some glue. Every day the space leak, you know. Need some glue. Yeah. Yeah. Your room not balanced. Yeah, I mean, just one of those I really respect. Yeah,
Yes, yeah. And those are the same that I have, the same course that I have to make the arch that I'm making. When I'm pretty. This is training. You wanna bring the.
I'm giving all the power to this. You want? Oh, we got a ladder. Worst case scenario.
Yeah, right. Oh, yeah. Yeah.
We gotta go get that walking fluid. Come on, man, you guys got what, 15 minutes? What's at your show?
It's gonna be dark in here.
Yeah. You're the keynote speaker. You didn't know that? You think so? Yes, I know so. You know what they're gonna hear? You know what they're gonna hear? Some jokes. Have you ever heard, do you know about it? He premiered that. It's over. Complete silence, and that was his point. Silence is as golden as making sound. Yeah. Oh, that'll be funny. What that would be. How low is everything?
piensan en dos boquillas. También en dos boquillas, pero a veces es historia. Tienen pedales,
Yeah, just kind of like picks up, kind of like air.
Yeah, I'll just do one. I'll do one on each of these pillars, Amanda. One in the middle.
Yeah.
So it goes boom, 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 boom.
Yeah.
Makes a big W.
Yeah. And I'm not sure whether it's one or not.
That.
Yeah. Careful. If I get all these done. Yeah.
Over there.
I used the single one. She had like 1.5 more.
Oh, yeah.
I do things later. I'm learning and learning the craft.
Yeah.
Over here.
Yeah, cool actually. Yeah.